Namaskara. A very pleasant morning to one and all. A warm welcome to the 58th Indian Orthodontic Conference to all the delegates across all the halls. We will be starting a scientific session sharp at 9:30. And I would like to just explain to you all that we are having this scientific session in two complexes. This is the Ocean complex. Where you're seated is the Ocean 1 or A, and next to it is the lounge, and beyond that is the Ocean B hall. And the second facility is the Galaxy complex, where we have the Galaxy 1, Galaxy 2, Tulip, Rose, Lily, and Jasmine halls, where the other scientific sessions are going to be happening. So with these few words, I would like to welcome you all once again. Wish you all a great time of scientific enrichment and a wonderful time at the conference. At this point, I would like to welcome the convener of the scientific session, Dr. Akshay Shetty, to say a few words. Over to you, Dr. Akshay.
Good morning, everybody. Ladies and gentlemen, esteemed colleagues and guests, welcome to the 58th Indian Orthodontic Conference. It's a privilege to stand before you today as a scientific chairman. This year, we gathered to explore cutting-edge research, innovative techniques, collaborative practices that are shaping the future of orthodontics. Our theme, Embracing Emerging Technologies, reflects our commitment to advancing patient care through science and technology. We have an exciting lineup of international and national keynote speakers and sessions that will challenge your thinking and inspire your practices. We have added two special editions to our lineup: the Legacy Lectures, showcasing the pillar of the godfathers of Indian orthodontics, and the other being important, the impact talks called the Illuminati, which means, Illumi means to light up, and Nati means our very own. These impact talks are on non-orthodontic topics like mental health, and also showcases some stories of fellow orthodontists who have incredible life stories, who turn challenges into triumphs. I would be failing in my words if I do not acknowledge the contributions of our chairman, Dr. Silju Matthew, organizing secretary, Dr. Anup Beludi, and the co-members, Dr. Prashant and Chandrasekhar in particular, for giving me a free hand and guiding me through many various challenges. To the flag bearers of Indian Orthodontic Society, President Jayesh Ralkar, Dr. Sanjay Lab, who've been truly remarkable in their involvement, making sure everything was fair and nobody was left behind. This reminds me of the phrase in Sanskrit, Vasudeva Kutumbak. The world is one family. A special mention to my postgraduate resident, Dr. Sonia Prabhu, who singularly helped us in everything from coordinating, troubleshooting things, several challenges, and changing in the scientific grid. Thank you for being here, and let's make the conference a memorable and enriching one. Without further delay, let's roll. Come.
A very warm welcome to our esteemed delegates, distinguished clinicians, renowned faculty from universities nationwide, and the honored dignitaries and speakers, many of whom have journeyed across borders to be with us today. To commence today's scientific session, I would like to invite to the stage the chairpersons for the first session by Dr. Paola Merlo. Please join me in welcoming Dr. Sarojini Joseph and Dr. Tulika Tripathi. Dr. Sarojini Joseph is a distinguished alumna of the renowned Government Dental College, Chennai. She has been the lead orthodontist on the cleft and craniofacial team at St. John's Medical College. And Dr. Tulika Tripathi is a senior professor and the former director principal at Maulana Azad Institute of Dental Sciences with a teaching experience of 37 years. I'd like to call on the chairpersons to introduce our speaker for the day.
Very good morning to one and all. It's a proud privilege to commence the first session of the first day of this conference and introduce you to our first speaker of the day, Dr. Paola Merlo. She's a graduate in 2001 in dentistry and dental prosthetics. In 2004, she completed her PhD in orthodontics at the University of Insubria. And in 2012, she completed her master's in adult patient orthodontics at the University of Siena. She has been teaching biomechanic courses with Dr. Giorgia Forelli since 2013 and speaker in Italy and abroad since 2010. An author of publications in the international orthodontic field, in particular co-author of the latest book by Charles Burstone, Chapter 16. Statically Determined Appliances and Creative Mechanics in the Biomechanical Foundation of Clinical Orthodontics, which has been published in 2015. She is a contract lecturer at the School of Orthodontics of the University of Siena since 2017 and tutor at the University of Insubria since 2021. She works as a freelancer in Switzerland, in Lugano and Locarno, ordinary member of SIDO, member of CBOS, member of the Swiss Dental Association, Ticino Society of Dentists, graduated from the Italian Board of Orthodontics in 2021. Over to Dr. Paola Merlo to enlighten us about the blend of straight wire and segmental technique.
Hello.
Thank you very much.
After a resounding success of our pre-conference course yesterday, I invite you.
Thank you, Dr.
With
Sariani.
deep affection also to this lecture.
Thank you. It's a big honor to hear this from you. Good morning to everyone. Okay, thank you. Good morning to everyone. It's a big honor to be here today. It's a great experience for me, a great occasion, and I'm really so happy. Yesterday it was a great day for me. I found so much interest in biomechanics and so much kindness, which is as important too. Today I'm going to speak of something a bit different, always based on biomechanics, obviously. And I'd like to underline the aspect that this is a very important topic for me, because even if in the last 20 years I always have been studying biomechanics and particularly segmented arch technique with my teacher, Giorgio Fiorelli from Italy, it's an evident necessity to have in my daily routine the instruments of straight wire technique. Straight wire technique continues to be the main instrument of my work every day with most of my patients. More or less, I can say that 70–80% of my orthodontic therapies are based on straight wire, which doesn't mean that 70–80% of my patients have straight wire and the other 20–30% have segmented arch technique. It means that in the whole treatments, I can identify more or less this percentage of segmented arch approach in many of my patients who have a blend of straight wire and segmented technique. And I also call this hybrid treatments. I want to start with this photo because it was a big honor to meet personally Professor Charles Barston in 2012 in Florence, and we could know a little bit each other. We had 2 days together, and I had the big honor to have to be co-author of this chapter in his last book, which was published after his death. Unfortunately, he died a few months after this photo. So I really thank you to be all here, particularly students and the practitioners who were yesterday at the pre-congress. I want to thank them particularly, and I also want to thank the president of IOC, Dr. Rahalkar, and the president of the Congress, Dr. Salio Matthew. And I want to greet particularly all IBO members here in Bangalore, from another IBO, Italian Board of Orthodontics, to Indian Board of Orthodontics. And this is exactly what I mean. to the right side, a segmented arch approach, and to the other side, a straight wire approach. Probably most of us, me too, are more confident with the vision of a straight wire approach because it's how we are accustomed to look at our orthodontic devices. In the segmented arch approach, in the segmented arch technique, we work with statically determined mechanics, and from a biomechanical point of view, we use force-driven mechanics. It means that the practitioner has totally in control the fact to manage forces and moments. He's able to design them, he's able to recognize them, and he's able to plan them. In the other case, straight wire is based on the 6 geometries of Barston, and we use shape-driven mechanics. Forces and moments are knowable only in a limited range and not completely and not so easily, not only with the use of a force gauge and the caliper as it happens in the segmented arch technique with statically determined mechanics. So to choose the first one or the second one, obviously, it depends on the case, it depends on the step of the case, and there is really no complete, no a certain rule in this, and no protocol. When and why use hybrid approach? It can be at the beginning of the treatment for the major movements, typically for the solution of a severe debite, but we can use also to manage the side effects of the straight wire. This is a particularly critical point because it can be a very, the segmented approach can be a very important arrow at our clinical arch when we have problems with straight wire and we are not completely able to solve them continuing with the continuous arch. And then, this is another topic in complex finishing movements. Sometimes, exactly the same orthodontic object we choose in the first step, in the first possibility, can be chosen also in the third one, from the solution of a major movement to the solution of a finishing movement. Obviously, not all cases need for segmented arch technique. And this is very important for our daily routine, particularly if we have many patients. Only virtuous practitioners who love so much segmented arch technique always want to use that. For example, my teacher, Giorgio Fiorelli, who never has night eye wires in his dental office. It's not my case at all. Cases like this absolutely can be completely managed with a straight wire from the first appointment to the second one. Also, a bit more complex cases with some expansion and to find a space for a missing canine. And also extractive cases, not extractions, are a reason by themselves to choose this, as all good practitioners in straight wire very well know. Also for some problems of canine inclusions, but sometimes it can be useful to join the possibility of some objects from straight wire. For example, I love a lot to use lingual arches or transpalatal arch joined to a straight wire approach. But a question is quite natural now. How complex should be the case to request for a segmented approach, for something different from the straight wire? Well, there is not a rule in this. It depends on many factors. It depends also on the knowledge of the practitioner of the orthodontics. It depends on how confident he feels with straight wire approach. And it's quite difficult to find in literature data on this point. We have some qualitative indications, but not really quantitative indication. In my work, this is what I do. If I have less than 3 millimeters of movement in 3 dimensions, I absolutely choose straight wire. If I have more than 3 millimeters in only 1 dimension of the space, the choice still can be straight wire. But if I have more than 3 millimeters in 2 or 3 dimensions of the space, in my experience, in my choices, I go to prefer segmented arch technique. This is for what is about the quantity of to particular vector. This is a cantilever which is able to produce a vector which has a buccal direction and a distal direction. The last direction I want at the beginning of this case is a vertical one, because the canine needs so much to go to the distal, but it also needs to jump the lateral route on the buccal side. And the box loop, the same box loop, after the managing of the torque, is also used to perform some tipping to the mesial of the root of the lateral. When the canine is here, the case is safe. The canine is going to be removed, and I will use a very linear, a very harmonical cantilever with no configuration to give only the vertical vector to the extrusion of the tooth. Other main topic for a segmented approach, as we so much explained yesterday in the pre-Congress conference, is the severe debite. The severe debite is something which, more than other movements, request for a segmented approach and needs some knowledge of mechanics and biomechanics, which are not the same. In the case of the bite, we need, most of all, vertical vector, which are directed to the apex direction. And it's not so easy for mechanical reasons to produce this only with straight wire or bracing with different levels. There are mechanical reasons for this. And so many times the choice is for segmented arch. This is the case of Gaia. Gaia is a young girl. She has quite good alignment. She has a class 2, premolar and molar. The class 2 is worse to the left side. We have midline shift, and we start with cantilevers for the solution of the bite. What we notice, obviously, in the first steps of the treatment is that we go to have overcorrection, and we'll notice also a different level between canines and incisors. There will be a moment I will need to introduce also the canine with an overlay night eye on the previous mechanics to go to have the transition from segmented arch technique with cantilevers to the straight wire technique. She has also some mandibular advancement. She had not much elastics because the first mechanics with cantilever is consistent with the correction from class 2 to class 1 in the posterior. The final case, the final smile. This is another patient of mine, quite old case. It was 2014. She's Melissa. Melissa is a bit older. She's already 16, and she's not a champion in hygiene, probably when she was a kid. She's very young, but she already has 3 important canal treatments, endodontic treatments, in the 1.6, 2.6, and 4.6. She's a class 2, overjet more than 6 millimeters. These are digital models. In such a case, my choice is for extractions. Which extractions? 2 molars in the upper, 1.6 and 2.6, because they are the most compromised teeth. With occlusogram, we plan the coming back with the VTO of upper incisors. And this movement will be possible because of the extractions. In the lower, we decide for a little coat of IPR, but not more. She will have no extraction in the lower. These are the intraoral photos. We have also some crossbite to the right side. This was a total straight wire case from the from the beginning almost to the last step with continuous arches, tiebacks, a very traditional mechanics, quite easy. And we had quite a good mesialization of 1.7 and 2.7. But what we noticed in the last step is that I had a bit difficulties in uprighting completely the root position of 1.7 and 2.7. Obviously, also other strategies can be performed, but in this case, the idea is to use a cantilever from 1.7 and 2.7 to the frontal part of the mouse, with only one single point of contact in the frontal. In this case, from 1.5 to 2.5, all my dental arch becomes the anchorage. The anchorage, which means for us the reactive unit in this case, so I can have anchorage problems in the frontal, and I'm already quite happy of the situation, of the occlusal situation in the frontal. So I ask the patients to use some vertical elastics to counteract the action of my cantilever, which is producing a vertical vector in the frontal, an extrusional vector in the molar, but more than this, one clockwise moment to the crown. So I will have the root coming to the mesial. Obviously, the crown of the molar has to be fixed to 1.5 and 2.5 with a metal ligature, which makes it a real torque movement. This is the final case, but more than the final photos, probably the panoramic can be more meaningful. Side effects of straight wire. There could be so many examples for this topic. I present you just one. This is Kimi. Kimi is a guy, he's missing 4.5, and I was too much ambitious in hoping to solve this case with the sliding mechanics, even if with a TAT, but it was not enough. In such cases where we try to mesialize lower molars with continuous arch, quite often we have to face the creation of a geometry tree. Geometry tree is is a mechanical situation described from Charles Barston, which gives me these two vectors, but more than this, also two moments. The moments go to the same direction, counterclockwise, and what we appreciate is the losing the possibility to lose some occlusion in the premolar area, with also some intrusion and losing of the contacts with the upper dental arch. So what to do? Many things, maybe also elastics or other choices, but my choice is this sort of zigzag sectional, which is very elastic, very low deflection rate, and I come out from the continuous arch strategy, something completely different. Use the TAT to product a vertical movement of canine and 4.4 to find again the occlusion with this final result and the final panoramic. Another case, sorry, this is a work in progress case. It's not finished, but it's quite extreme, so I had the pleasure to present you. This is Michaela. Michaela is a young girl of 8.5 years old. She has a supranumerary tooth and one central incisor 2.1, which is very much rotated, probably 150 degrees, something like that. You can see the 3D exam, and you can appreciate not only the rotation on the frontal plane, but also the so much horizontal position. Maybe it's not so visible in the photo, but it's very visible in the 3D exam. Obviously, the supranumerary tooth is going to be extracted very, very quickly, but we have to solve all the other problems. This is the mechanics we go to choose. It's a very long cantilever. It comes from 5.5 to 6.5 baby molars. And I have a bracket which is bonded on the palatal surface of the incisor. We call this a mill blades mechanics because it's able to create such a big moment with low force at the incisor. She had also an expander. This is not very important. This is what we did. This is the design of the mechanics in the passive shape and in the active shape. When we go to link this object with a single point of contact at 5.5 and 6.5, we have this mechanical scheme. Two forces, low forces, 50 grams. Yesterday we spoke a lot about the quantity of forces, 50 grams, and with a general force from the sum of them two, which is able to product at the distance of 30 millimeters, more or less, obviously, we have range in this blending mechanics, so much, 2,400 millimeters, which is a huge moment. And actually, in 3 months, the tooth is able to be rotated. You can see it in the second image. Obviously, with some periodontal sufferance, but we could not do other than accept some periodontal risks in this case. And then, this is the object. This is the most famous mill blades in Italy, in Sicily, Marsala. The root seems still to be quite safe, we hope so. And now I have the problem of the horizontal inclination. I need so much to change the torque of this tooth, and I really don't feel safe in performing this with a straight wire approach. We need something different. The choice is for a cantilever. The same bracket is now rotated from the horizontal position to a vertical one, and it is always in the palatal surface with a transpalatal arch, which takes the place of the expander. In this case, the cantilever is activated, as you see, with a single point of contact at the transpalatal arch, and the MF ratio we realize on the incisor is exactly the length of the cantilever, so 22 millimeter more or less. This is what we can obtain, always with periodontal stress. This is obvious, but all orthodontics is based on periodontal stress. And now, from here, we have to continue. So you can see a bite because I had so many problems in the contact, in the pre-contacts between 2.1, which is already a weak tooth, with the lower. Much easier case. She is Virginia. Virginia is 14.10, almost 15. She's a young girl. She's very fashion, and obviously she doesn't want braces. But she presents a medium severe deep bite, in my opinion. I'm very scared of deep bite. I don't feel safe in proposing her aligners from the first step. So aligners, for me, in my treatment plan, will be the second step of the treatment. The first step is to choose a segmented arch approach, which gives me the possibility to modify, to improve the situation of incisors. She has a retainer. You can see it in the digital model to the right side. And she has this cantilever coming from the molars with a single point of contact between the retainer and the cantilever itself. And it works exactly as the Melissa's one you have seen before. Sorry. The position of the cantilever is changed because I noticed some cant. So I wanted also a little bit of correction of the cant. And then you see the case before. Wow. Hello. And you see the case before the starting with aligners. Final case after aligners, final smile. Very easy case in young adult. The necessity to intrude the 2.1 before a prosthetic restoration for the aesthetics of 1.1 and 2.1, the central upper incisors. You can see a very easy aesthetic bracket and only one cantilever. These sort of mechanics where we join the cantilever with the retainer are really less visible. In intraoral photos, they are quite visible because obviously we have the open mouth, but in the smile, the upper lip goes to cover the cantilever. So generally, patients accept it quite easily, in my experience. Thomas always requests for aligners a patient with a good posterior occlusion, but 1.7 is in scissor bite, and he has quite a lot of deep bite. Deep bite is solved, as you have seen previously, but in the upper and in the lower. And believe me if I tell you that it's not so visible, even if it's not so nice to see here. Retainer in the posterior and the specific cantilever with occlusal anchorage, occlusal management, not to have moments on the 1.6, a very elastic cantilever coming from the front to the back to go to take the 1.7, which is in scissor bite. This is the passive shape of the cantilever. This is before Invisalign, before aligners, sorry. Final case. Other deep bite. I'm sorry, I have quite a lot of deep bite. Lisa is 13. She had 5 years functional therapy with positioners, and she was really not very happy of this. Quite severe, the bite, class 2, particularly to the left side, or class 1 to the right side. Absolutely segmented arch technique approach. Cantilever sectional from lateral to lateral. Some cantilevers with configuration, intrusion with cantilevers also in the lower, but I still have the problem of a scissor bite of 1.7, and I use exactly the same, I use something different from Thomas, which is a box loop only to 1.7 coming from the buccal side. Thomas was a case coming from the palatal side. In this case, I come from the buccal side, always with a very elastic object, a box loop. This is not a determinate statically system, it's an indeterminate, but the load deflection is always very, very low. And my reactive unit is obviously the upper dental arch. Final case, final smile. The possibility to have blending with the segmented arch technique is obviously possible also when we have lingual approach. I have no big passion for a lingual approach. Absolutely, I appreciate so much who practices it, but can be a good choice to join all the instruments I have from segmented arch technique, which are quite often less visible, with lingual approach. Zdravko. Zdravko is an adult man. He's 34. He practices box. You can appreciate so much muscle action. And he has this situation. So much lateral deviation to the right side. No TMJ symptoms. Cant of incisors. Maybe I show you all the checklist of problems. Cant of incisors, right crossbite, vertical posterior compensation, and then 2.7 scissor bite, and severe extrusion of 2.6 and 3.6 missing. Quite complex case. In such a case, we plan a centering of the mandible. And if I think to center the mandible in such a lateral deviation in an adult patient, I have to think of the condyle position. So we ask for a 3D exam of condyles. And what we appreciate, he always grew up with the lateral deviation, what we can appreciate is the quite center position of condyled. These cases after the centering, this is the centering simulated in the digital models. After the centering with provisional raising, we have to check the patient for 3 months, more or less, to be sure that he is able to tolerate the centering with raising. And this will be my therapeutic position. From this, I will have to start to use mechanics to change the position of teeth, and they will have to be able to stabilize the not orthopedic, but the therapeutic position I have realized with the resin. Resin is Triagel from Dentsply. Unfortunately, we don't have it anymore because it's no more productive in this moment. This is the image of the mandibular repositioning in the lower. The lower arch is quite well aligned. And then, in my opinion, we have to start to work solving the key point of the case, which is in the position of 1.3, 1.4 with the cantilever. If I will be able to change, to solve the crossbite in this position and to have some expansion of canine and the premolar, I expect to start to see stability in the case. So I start from that. I have a lingual arch which is used in the lingual arch shape in the palate. It's obviously handmade done, not from technician. And this arch is able to give me the anchorage for the cantilever, but also some expansion in the posterior. The shape of the upper dental arch starts to change. These are all passages. Oh, a request of the patient, obviously, was no brackets. He never wanted brackets in the frontal, only Invisalign and only aligners and not surgery. So it was a bit challenging to treat him for me. I had to use also lingual braces after the first solution of the crossbite. Frontal images, the changing of the shape from a frontal view with lingual braces. Lateral section to manage the expansion in the premolar regions. A TAD in the lower to have the uprighting of the lower molar, 3.7, and a quite elastic cantilever like the Thomas's one to solve the scissor bite of 2.7. This is the case before aligners, and I still have quite an important problem. I don't feel safe in treating with the aligners, which is the extrusion of 2.6. 2.6 will be managed with segmented technique at the end of the treatment or in the last steps of aligners. These are aligners joined with a sectional for the intrusion with quite good occlusal contact to the premolar and the second molar for the intrusion of the molar. They can work together. The only movement I decided not to perform was the uprighting of 4.6 because he would have had a crown in the future. And so the timeline therapy is so made. We started with mandibular position, solution of the crossbite 1.3, palatal expanding arch, forced molars expansion, uprighting, scissor bite, aesthetic alignment. Aesthetic alignment, in my mind, is the same thing of straight wire, obviously. But then I still had something in segmented approach to do, which was a 2.6 intrusion. This was my timeline therapy. Final case, maybe it's not a perfect case, but it has a high level of difficulty, and I'm quite sure he was very much helped from the very good muscle activities in this case, even if he was a high angle case, and this is quite a topic, I think. Okay, Tony Elian, very short case, but quite complex. Tony Elian is a young guy, 14. he has a complete scissor bite from 2.4 to 2.7. This is the model's very good alignment. His school dentist told him he has a wonderful mouth, but the wonderful mouth has these occlusal map. Have no contacts completely to the left side, obviously with vertical compensation. You can see that the goniac angle is completely different from the right to the left. It's much deeper to the right side. This is the case, vertical compensation. Only the first step of solution of the scissor bite is performed with TAT, mandibular repositioning to the right side, and TAT to have the intrusion and the lingually position, the lingual repositioning in the upper and the buccal repositioning in the lower of the group of teeth. Only with elastic chain, but in any case, it's a segmented arch technique. Then I'm moving to straight wire, and it becomes a very easy case when I have solved the scissor bite. Final case. Final occlusal maps. You can see how the contacts go to change, which is the most important functional aspects, obviously. And look at the orthopedic changing too, because the correction of the vertical previous compensation gives me the possibility to have also a better fascial situation, a better skeletal situation with the leveling of the goniac angles. This is my last case, and I really thank you for your attention. She's Umran. She's a young woman, 23, and she's a class 3, open bite, high angle, a quite important sagittal problem, and also a quite important vertical problem. In the first visit, I tell this woman she's a surgical case, but in Switzerland, now she's too old, 23, to have the economical insurance for having surgery, and surgery is very, very expensive. So we decide to treat her with an orthodontic approach with no surgery, with some compensation if possible. We appreciate quite a good occlusion to the left side, very bad occlusion to the right side, deviation, midline deviation, and open bite in the frontal, and almost 5 millimeters of discrepancy between 1.3 and 4.3 to achieve the class 1. Segmented arch technique approach, obviously. This is a utility arch which is going to protract and extrude the incisors according to a geometry 5 in this way. Then a TAD is used to perform the mesialization of the right upper premolar and canine. There is also some, if you notice, some raising with a very, very small repositioning of the mandible to the back, which can be considered a risk movement. But she was very easy in going a little bit back. This was quite interesting in this case, but I checked very much the TMJ point to the right side. This is the line of action of the force. You know, who comes from segmented arch technique is so in love with the line of action of the force. This is the passage from segmented approach to straight wire. Maybe funny that you don't notice still a bracket on 2.3, because it was the most fixed point of the treatment. And only at the end, in the finishing steps, she had the brace there. She didn't need before. Transpalatal arch. Just a consideration of the moment. This is a direct use of a TAD, but the moment we product is on the occlusal plane, so I have no risk to have the losing of the tax. This is the good way to use moments in the direct use of TADs when they are applied straightly to the TAD. pure straight wire in the last steps, some elastics, final smile, final case, retainers, beginning cephalometric data. Please notice SN pogonion is 83 degrees. Final data, SN pogonion is 80 degrees now. So I have to imagine some repositioning of the mandible too. And maybe you ask if she had any problems from this, because the back repositioning is a very discussed topic. We have 10 years follow-up in her. This is 10 years follow-up. I treated her in 2014, and probably you can appreciate it's true from the face, because now she is much more than 30. So when consider SAT approach, take-home message, for this kind of movement, debite, molar subwriting, transposition, asymmetries, border cases surgery, like the last one, torque, and most of all, these 3 cases. For which quantity, this is my opinion. You can find also data for the first information, not for this. 3 millimeters in 2 or 3 dimensions of the space. More than 15 degrees of rotation in any space dimension. I thank you so much for your attention, and from me and from my whole staff, and from Giorgio Fiorelli, who is my teacher. I really thank you very much. It was an honor to be here.
I thank you, I thank Dr. Paola.
Our heartfelt. Can you hear me?
Hello.
Hello.
I thank Dr. Paola for this wonderful lecture, a combination of segmented and straight wire, which is one of her pet favorite topics. And I think for the malocclusions of India that we have to treat, I think this is a very good eye-opener for us on how to treat the difficult cases that we are very often that we have in our practice in India. And I also want to thank you because we need, India needs to know more about, more biomechanics knowledge, because we cannot read or speak if we do not know alphabets. So what alphabets is to our language, biomechanics is to orthodontics. So I thank you so much for opening our eyes and showing us all the possibilities that we can do, because we have a great array, a big challenge of complex malocclusions in our country. Thank you. Any questions? We can take questions. Dr. Paola has finished well on time. We can take any questions. If there are no questions, we'll... Oh, there is a question. Yeah.
I would like to call upon the chairpersons to felicitate Dr. Paola with a token of appreciation. I would now like to call on stage Dr. Pradeep Jain to present our chairpersons with the certificate of appreciation. Our next exciting session features a true legend of the Indian orthodontic community, Dr. V P Jayde. I'd like to call on stage our esteemed chairpersons for the session, Dr. Balakrishnan Jayanan and Dr. Sandesh Pai. Dr. Sandesh Pai is an ex-professor and head at Jaipur Dental, KD Dental and Vaidehi Dental College with a noteworthy 28 years of clinical and teaching experience. He is currently a consulting orthodontist and operates his own practice in Bangalore. Dr. Balakrishnan Jayade is a graduate of Government Dental College and was commissioned in the Army Dental Corps in April 1991. He is currently holding the appointment of commandment at Air Force Institute of Dental Sciences and the dental advisor for the Indian Air Force. I request our chairpersons to start the session.
Good morning, ladies and gentlemen. My co-chair, Dr. Sandesh Pai, joins me in thanking the 58th IOC for giving us an opportunity to chair the most important Legacy Series lectures. And we happen to chair the first of the Legacy Series. The Legacy lectures are being delivered by the true legends of Indian orthodontic community. And before I take the opportunity to introduce the legendary legend, may I invoke my prayers for all the Gurus, Guru Brahma, Guru Vishnu, Guru Devo, Maheshwara, Guru Sakshat, Parabrahma, Tasmai Shri Guru Venma. The lecture being delivered is on probably 60 years of one's experience. The longer you are able to look back, the farther you can look forward. And this is going to be delivered by Professor Vijay Pandurang Jayade, Doyen of Indian Orthodontics, popularly and fondly known as Jayade Sir. He was born in a small village, Kankumbi, in the present Belagavi district in Karnataka, much before independence, to be precise, 6 years before India became independent. His schooling and pre-professional colleges have been in Hubli, Dharwad, and Pune. And he graduated from Government Dental College, Mumbai in 65, and in 67, he became a postgraduate from the same institution. Throughout his journey, he brought in best practices by virtue of his travels to UK, USA, Japan in the years between 676 and 82. He has also attended the Glasgow Dental School at the stroke of millennium on T.C. White scholarship. The esteemed professor was the professor and head at SDM College of Dental Sciences since its inception in 1987. He superannuated in 2006, but went on to pursue his passion for teaching by providing his services to dental college at Guntur. Needless to say, he has been mentor, guide, examiner for UG, PG, and also MDO program under the aegis of Royal College, Glasgow. As far as the society is concerned, he has been a former president, the editor of the JIOS, organized various PG conventions, national conferences, various education programs. For his contribution, he has been a recipient of Dinsha Vacha Memorial Award by the Mumbai University, T.C. White Scholarship, IOS Outstanding Professor Award, and many, many awards. I had a small chat with his esteemed son, Professor Chetan Jayade, and I could make out that he's a multifaceted personality, a great humanist, social worker, and a great lover of classical music. He is well published and published 2 very important books. And he's also published, for your information, the Bhagavad Gita for Common Man in Marathi. and we are looking forward for the English translation, sir. Truly, in my view, the Dronacharya of Indian orthodontics, and I am also pleased to say that the co-chair happens to be one of his first postgraduate students. I would request you to share a few thoughts before you hand over the mic to the professor.
A very good morning to all the delegates and office bearers present in this beautiful hall. I quote William A. Ward's, "A mediocre teacher tells, a good teacher explains, the superior teacher demonstrates, and the great teacher inspires." It is my privilege and honor to chair Dr. V P Jayde sir's scientific lecture, who has been my guide and mentor. I am sure his lecture today will enlighten all of us present here. Without taking any more time, I proudly present to you all the great teacher of our era, Dr. V P Jayde sir. I welcome you, sir.
Suprabhatam. A very good morning to all of you. At the outset, I would like to thank Dr. Silju Matthew and Dr. Akshay for inviting me to this august gathering to deliver a legacy talk. I am very much thankful to the chairman and co-chairman for their words of appreciation, and I humbly accept their compliments. Now, I have been asked to give a legacy talk. So, what's legacy? Legacy is something that is passed on. It could be monetary or other assets, but more importantly, it is faith, ethics, and core values. In fact, those highest qualities, virtues, which make a person's personality, character, and it also determines his aim of life. It applies not only to a person, but to a group of persons, to an organization, and perhaps to the whole nation. So I thought that I would present before you the legacy that we have inherited from our forefathers and that we are going to pass on to the next generations. The title that I have chosen is "Longer you look back, the farther you can look ahead." These are the famous words of the celebrated Prime Minister of Great Britain, Mr. Winston Churchill. And I am going to take you as far back as the starting of orthodontics as a real specialty, and then bring you to the present scenario. Now, why should we look back at our legacy? That is because we stand on the shoulders of our forefathers. What we are today, we owe much credit to our forefathers. And therefore, we should have gratitude to them. We derive inspiration and may learn from their mistakes. We don't have to keep on repeating the mistakes which they did. We can improve upon them. So the scope of my talk is going to be our legacy from the legends abroad, our legacy from Indian giants, Indian Orthodontic Society, a brief history, the postgraduate education in India, my orthodontic journey, legacy from those who enrich the Indian orthodontics, the future as I see it, and some advice to the youngsters. Now, those are the legends who make us proud. And if we divide the modern orthodontics up to 1920, up to 1960, the earlier era, and after 96, the next era, then those are the various legends, starting from Farrar and Case and Dr. Angle, and going through Sassoni and Tweed and Begg. The more recent stalwarts would be Steiner, Graeber, Burston, Ricketts, Kessling, father and son duo, Andrews, Roth, Bennett, McLaughlin, Prophet, etc. Now, many of their contributions are known, but some may not be known. For example, we know that Steiner has given us his SNA, SNB, and we use it daily. And he was a great clinician. But it is interesting to note that he did his research on stainless steel wires for a thesis that he had to submit when he appeared for his ABO exam. Harold Kesseling invented what is known as the tooth positioner, which is the precursor to aligners. Now, many of you might be using aligners, and I'm sure all of you are familiar with this appliance, but some may not know that the precursor for this was Harold Kesseling's positioner that was meant for finishing the treatment. Ricketts' contribution, we know that he gave us the cord helix and the utility arch and his segmented arch technique, his way of treating the orthodontic treatment. But then he also had great contribution to aesthetics by way of his emphasis on golden triangle. We also know about the pioneer biologists like Sandstead, Oppenheim, Ketcham, Moyers, and Reaton. But let us not forget the contribution from the engineers, both past and more recent ones. For example, Rudolf Hanau was the one who introduced what is called as Hanau's dental surveying apparatus to decide the correct arch form. Gilbert Fish, another engineer during those days, he invented what is called as occlusograph. And both of them defined several terms which we use routinely in biomechanics, starting from force, moment, center of rotation, and going up to Newton's laws. Unfortunately, their contributions were not recognized till about 1955, when Drenker, one of the engineers himself by education, entered orthodontics, started studying orthodontics, and he, along with his guru, Hag, they established the biomechanics as one of the branches of orthodontics. And then there are many other people like Koenig, who worked with Burston, then Fahrenwald, who developed certain wires, Wilcock, who gave us the famous orthodontic wire, Goldberg, known for his TMA wire, Kusi, etc., etc. They defined several terms and concepts. They gave us various equipments which are very useful, and they also introduced the research methods like halography and recently the finite element method. They have developed different materials, and those are the ones which are very useful. So let us not forget the contribution of the engineers, and those of you who are interested in knowing more about this could go through my article published in the Indian Journal of Orthodontics 2018 December issue. Now, some of the Indians or Indian origin people have made great contribution, and they have shown in USA, and I'll enumerate few of them. Dr. Ram Nanda and Ravi Nanda, Varun Kalra, Rohit Sachdeva, Sunil Kapila, and Dr. Sarandeep Singh Huja. Those are their photographs. And the young brigade, Pradeep Shetty, Sumit Yadav, Madhur Upadhyay, all from Belgaum. Sanjay Suri, who passed from Chandigarh, who is heading a department in Toronto now. Dr. H.S. Divakar and Dr. Meenakshi, my own students, they are doing very well in this stage, and we should be proud of their contribution. Those are the various people I mentioned. Now we come to the history of orthodontics in India. It was called orthodontia during those days. And Dr. H.D. Merchant gave a series of talks in Nair Dental College in Mumbai, then called Bombay, on orthodontia in the year 1935. And that was the beginning of orthodontics in India. The first orthodontic department was started in 1939 in the same college with Dr. Merchant as the HOD. And these were the various pioneers, Indian pioneers, and they had different background. They were trained at different places. Dr. H.D. Merchant and Dr. Ashok Modi were trained in Germany. Dr. Prem Prakash, Dr. Ram Nanda, and Dr. Naishat Parikh, Dr. K.K. Mistry, they were trained in America. Dr. Sheikh was trained in India, but then with his brilliance and capabilities, he rose to the position of a very eminent teacher, comparable to any one of them. Those were the founder members of Indian Orthodontic Society, going in an anti-clockwise direction from top, Dr. Merchant, Dr. Naishat Parikh, Dr. Prem Prakash, Dr. Sheikh, Dr. K.K. Mistry, Dr. Mohandas Bhatt, and Dr. A.B. Modi. A brief history of Indian Orthodontic Society. It was started as the Mumbai Study Group in 1961 and later converted into Indian Orthodontic Society in 1965 with Dr. H.D. Merchant as the first president and Naishat Parikh as the honorary secretary. And there are many firsts to the credit of IOS for which we should be proud. Ours is the first dental specialty organization in India. We were the first to hold a conference, a specialty conference, and that was held in 1967 in New Delhi. We were the first to start a journal, the Indian Orthodontic Society Journal, in 1968 with Dr. Merchant as its editor. And we were the first to start a board, the Indian Board of Orthodontics, that started functioning in 1999 in this very city of Bangalore. Now let's see how the IOS was during the olden days. There was a small membership, but members were keen to learn and the office bearers were motivated to uplift the profession. Now we have a membership of more than 6,000. During those days, the membership was in 2 figures and within few years it crossed to 3 figures. Besides the annual conferences, very few continuing dental education programs were conducted. We learned from our teachers and by discussing with each other. There were hardly any overseas speakers. Now that's one of the photographs of IOS conference. You can see the small gathering. And the conferences during those days were held in dental colleges and in a classroom. We didn't require big auditoriums like we require today. They were inexpensive because the food was provided by the college canteen. And at the most, one dinner was organized outside. And there were very few overseas speakers. That's me. This is a little later in another IOS conference, a slightly bigger gathering, but still it could be fitted in a college classroom. And the first notable overseas speaker was Professor J.P. Moss, who was invited to the 10th Orthodontic Conference held in Mumbai. And that was the time that the IOS conferences really started becoming big, and they started being hosted in bigger places, usually in hotels. Let's revise the orthodontic post-graduation education in India. Started in 1959 in Mumbai at the two dental colleges, the Government Dental College, formerly called as CM Dental College, and Nair Hospital Dental College. And dental colleges at those various other places, they were started a little later. Initially, it was a 2 year program. Later on, gradually it increased to 3 years. Those were the first two batches of MDS in Mumbai in the Government Dental College, and teachers were Dr. Shawri and Professor Iyer, and amongst the students are Dr. Sheikh, Dr. M.R. Joshi, Dr. Kundan, Dr. Mohandas Bhatt, Dr. Shete, and Jairam and managers. And some of them later became very well established teachers. The postgraduate education in North India started in Lucknow in the year 1965 with Professor Ram Nanda as the head of the department, and the teaching there was based on standard age-wise speed technique. And after he migrated to USA, Professor D.S. Gupta and subsequently Dr. D.N. Kapoor, and later on, of course, many other people, it continued. In the North India, the Lucknow pass-outs, they continued teaching in other places, like Professor Uttareja at Postgraduate Institute of Medical Research, Chandigarh, and Professor Kharbanda at AIMS, New Delhi. Now, talking about the appliances during those days, many teachers who had undergone training in Mumbai and Lucknow, they followed the appliances which were taught to them. In Mumbai, in GDC, it was basically BEG. In Nair, it was edgewise, perhaps Jarabak edgewise, and in Lucknow, it was standard edgewise. So, those people who headed the departments after they graduated, they continued with whatever appliances they were taught. Now, I'll go through my orthodontic journey, not so much to give you the details of what I underwent, but basically to tell you the transformation of the profession as I saw it from 1965 onwards. I joined JDC in the year 61, BDS in 65, MDS in 67. Practice started in 68 and teaching from 87 to 2010. And my teacher, my guide was Dr. K.L. Shawri with a long string of qualifications. He was MSc MBBS, MDS, and PhD in nutrition. For all practical purposes, our boss was late Dr. H.S. Sheikh, a very stern disciplinarian, and because of him, we are what we are today. We had the benefit of teachers from Nair College as well, because every week we used to go to Nair one day to attend their seminars and case presentations, and one day a week their students used to come to GDC. So the teachers in Nair were late Dr. A.B. Modi, Dr. Naishat Parikh, and Dr. H.D. Merchant. We had the benefit of learning from them as well. The PG program during days was less of reading, but plenty of donkey work. Let me give you an example. You are given a 1 mm diameter wire of, let's say, 6 inches. You are asked to cut it exactly in 2 pieces. The length would be measured. And then the 2 cut pieces are supposed to be filed in such a way that the faces should exactly meet and match, and that would be checked under a magnifying glass. Now, those of you who claim to be good, having a good hand, can try this exercise. There were very few textbooks during those days. Salzman was the main textbook. Gives a lot of information, but it is so haphazard that it is a thoroughly boring book. If any of you suffer from insomnia, I would advise that you procure the book and start reading. Within 5 minutes, you will fall asleep. We also had Strang on standard edgewise, tweed edgewise, Oliver's book on labiolingual technique, and later on, Tweed, Jaraback, and Begg books became available. There were few journals available, mostly American Journal of Orthodontics and some Anglo-Orthodontics issues. There was an acute dearth of materials, so much so that the imported brackets, edgewise brackets, were kept under lock and key in a cupboard, and you were given a permission to look at them at a distance. And if you were very fortunate, then the cupboard would be opened and the brackets would be placed in front of you, but you were not supposed to handle them. There was a lot of confusion about the appliances, which ones to use. Removable screw plates, activator, or screen, fixed labiolingual. Now this lingual technique was quite different, mind you. It was a lingual arch and a labial arch, and then some attachments soldered for bringing about certain tooth movements. We were doing some twin arch treatment also, but not using the standard brackets which were developed by Dr. Johnson, which are shown there. We had a plier used to crimp the twin bracket-like configuration, which would weld on the bands and then use. Then edgewise, which one? Tweed or Jaraback? When we were in second year, one gentleman by name Udelson was deputed by Unitec, and he came and talked to us on universal technique, and that confused us even more. And towards the end, we were introduced to Begg by Dr. Prem Prakash. And then the things started falling in place. He was a gifted technician, excellent teacher, well-informed, systematic, very open and honest. If he didn't know a certain thing, he would admit so openly without any hesitation. I started my practice in Hubli. I was doing general dental practice as well as orthodontic practice, because during those days, there was very little awareness about the orthodontic treatment. And patients were scared to hear that some teeth might have to be extracted, because there was this notion that if you extract the upper teeth, then you would lose your eyesight. The fees were very meager. They were usually in 3 digits. Can you imagine that? And if I crossed over to the 4th digit, then the patient would run away. Patients' perceptions, I told you, very wrong notions they had, and the equipment was very primitive by today's yardsticks. There was dearth of materials and equipment, great difficulties in importing. Except in conferences, we had very little CD avenues, and introduction to latest equipment was practically nil, but when it was obtained, then there were associated problems. I started with 0 orthodontic patient because although I was the only orthodontist between Pune and Bangalore during those days, except of course Dr. Shetty in Goa, for the first 4 to 5 months I had no orthodontic patient. So I was compelled to do general dental practice. There was an acute shortage of foreign exchange, and materials were very difficult to procure. Procedure was very tedious, and custom authorities were very, very suspicious. They would feel as if we were importing something contraband. When the stainless steel band material was imported, it was not considered as something required for medical profession, but because it was stainless steel, the duty levied was 200%. The continuing education programs were basically from the IOS, and there were hardly any overseas speakers. So I visited abroad. 1976 and 82, I went to the States and also to other countries. And 86, I went to Singapore. I took 2 courses in Kesling and Rocky Center and visited these other places, met and interacted with many eminent people. Now that's the Kesling and Rocky Center at Westville, Indiana. Those were the teachers, Dr. Harold Kesling, Robert Rocky, Peter Kesling, Thomas Rock. This is during training there. I was also privileged to meet Dr. Graver in one of those visits, and I had the privilege of interaction with the Japanese orthodontists. What I observed was beg or standard edgewise were still prevalent and thriving in those days, 1976. But later on, they slowly started giving way to pre-adjusted edgewise treatment. There was a gradual acceptance in America for functionals, Frankel and twin block, etc. Computers were entering in a big way in teaching, research, and practice. And lingual orthodontics had started gaining ground. One of the earliest attempts of lingual orthodontics was by using beg bracket by one gentleman, Dr. Page. 1976 onwards, there was a gradual acceptance of orthodontic treatment. Material position eased a little. Some Indian products, basically some band material, beg brackets, etc. became available. And then pre-adjusted edgewise started making a strong impact. I started as a late entrance, but then I took help from friends like Dr. Rangachari, Dr. M.K. Prakash, and Dr. Jyothindra Kumar, and I was able to lift myself to become a satisfactory teacher. And I can say that teaching is a very, very satisfying and enriching experience. That is my personal feeling. This is SDM Dental College where I taught. Before that, I had a small stint at Belgaum as well, KLE, for a few months, from 2006 to 2010 at Sibar Dental College. And our PG training started in 1991, and we had some overseas speakers, that is Professor Malcolm Jones from Bristol. Okay, so this was my journey. Now the things started changing in the national scenario. and we had international speakers at IOC conferences, starting with Dr. Dale Wade, who conducted the first pre-adjusted age-wise course in India at Trivandrum, followed by Dr. Vix Alexander in Mumbai, and then a galaxy of orthodontists from many countries, including Dr. Ricketts, at the first international conference in New Delhi in 1995. And then we had exposure to many speakers of international repute who you can say are the names who's who. And they were the speakers on modern age-wise appliances, modern beg or tippage, functionals, biomechanics, finishing, TADS, growth, aesthetics, and whatnot. So that is how the continuing education transformed from practically no overseas speakers to many great speakers. And I had the good fortune of meeting and interacting Dr. Mollenhauer in 1993 and Dr. Burson in 2013, where he was invited. So the change from beginning to the present has been from a fledgling practice to a well-established and accepted specialty. Now, I am going to enumerate some people of our own people who have enriched the Indian orthodontics. I do not have time to name all of them. So basically, I have restricted myself to the people of my generation or the next generation. And my audience, I presume, is basically the younger generation up to the age of 40, 45. So they might not be knowing the contributions of senior persons. So that's why I have selected some of them, and please forgive me for not mentioning all of them. Now they are all eminent teachers and clinicians, starting with Dr. M.K. Prakash. He had the courage to change over from his back practice to pre-adjusted age-wise practice without any formal training in pre-adjusted age-wise. And afterwards, he conducted many courses along with late Dr. Ravindra Sabre to train others in pre-adjusted age-wise technique. And M.K. Prakash was also one of the first one to use the TADS. Late Dr. Ravindra Sabre, another very able clinician and teacher from Pune, he joined hands with Dr. Prem Prakash in conducting these pre-adjusted age-wise courses. Dr. Sadashiv Shetty, he emphasized the use of headgears and functionals, and he strengthened the pre-adjusted age-wise roots in India by conducting number of courses in Davangere, and the tradition is still continuing, and that is where many people who didn't have the basic training in pre-adjusted age-wise, they learned their technique. Dr. Vinod Verma and Mrs. Asha Verma, they were quite unique in starting the lingual orthodontics in India. To my knowledge, they were the first ones, and they started it with beg inverted bracket. They also introduced tippage technique in India. Dr. Jyothindra Kumar, a researcher par excellence, and being a clinician and a teacher. Additionally, he also rose to the position of the Joint Medical Director. Am I correct, Dr. Jyothindra Kumar? Of Kerala government, a very distinguished position. And Dr. Girish Kandikar, a man with magical hands, I would say. You should see his wire bending skills. And a great speaker. Dr. O.P. Kharabanda, researcher and author, he has authored the textbook. Dr. N.R. Krishnaswamy, another very good clinician, teacher, and an international speaker, and many others. As I said, I am not in a position to name all of them. Kindly bear with me. Now, what I saw over the period of these many years, starting from 1965, there has been a changing paradigm in many ways. Orthodontics became more of a science from being predominantly an art. When we learned, it was basically an art of treating the patient, and the scientific aspect was much less. Now, it is both a science and an art, and the emphasis on diagnosis, biomechanics, that is a great change. During our times, there was hardly any knowledge of biomechanics, but now biomechanics is an integral part of training as well as treating. Emphasis on understanding, emphasis on avoiding pathology, greater understanding of growth and its manipulation and changes at the cellular level, etc. Those have been the changes in our knowledge. I have still some time. Orthodontic treatment gradually became aesthetic-centered. I wonder if it was to attract more patients, because the child population in Western countries remained the same or it started declining, and the number of orthodontists were increasing. So they had to attract the patients. And I don't know if that was the reason why aesthetics was given more and more importance to attract more adult patients. Hard tissue parameters have given way to soft tissue parameters. Several new avenues have opened, like invisible braces, lingual orthodontics, aligners, etc. Multidisciplinary approach, ortho surgery combination, ortho perio combination, ortho prosto combination, they have entered. The scope of treatment has expanded tremendously in treating facial deformities, including cleft lip and palate treatment. We had hardly any training in treating the cleft lip and palate patients, but now it is a part of your curriculum and you are exposed to that treatment. Complex malocclusions, mutilated occlusions, etc., are being treated. Another welcome change is that the leaders are now emerging or have emerged from East. Earlier it was basically the leaders from America and European countries. Now we have leaders from East, from Japan, from South Korea, Taiwan, China, and of course from India. And they are the leaders in the field of materials, TADS, lingual orthodontics, orthognathic surgery, biomechanics, biology of tooth movement, and so many fields. The innovations which have changed the orthodontic practice, the first one to my mind was orthodontic bonding. The present generation may not be able to grasp how difficult it was to band a patient all the teeth. First you had to place the separators, which was a very painful affair, and the patients would literally cry. And then to make the bands, to weld and solder the attachments, then cement them, it would take hours together, and it was a very tedious job. Orthodontic bonding changed all of that. Newer materials, especially the arch wire materials, have entered, and especially the NITA wires, TMA wires, etc. TADS and MARPE have made your life much easier. And there is an increasing use of technology in 3D imaging in diagnosis, CAD/CAM, etc., in manufacturing of brackets, self-ligating brackets, aligner appliances, and so on and so forth. So there has been a whole lot of change, and that is the legacy that we have inherited, and that is the legacy that we are carrying forward. Now, I'll talk a little about my perception of the present, and I have some khushi and some gum. I'm happy about few things, I'm not so happy about the other things. Let me enumerate them. In clinical orthodontic practice, profession has been accepted and is well recognized. Practice standards of many in India is on par with the international ones, but there is a cutthroat competition and the young graduates are forced to carry their instruments in a suitcase and jump from one dentist to another, and they are not able to produce good results. The results are substandard. In the education, the postgraduate program has crystallized well. Some departments are doing exceedingly well in teaching, research, and publications, and it's a very happy thing to see the increasing numbers of Indian speakers in international conferences and continuing education programs. But the regret about the education is other departments have to travel a long way. There are problems with management. When I hear those things, I feel very sad. There is lack of resources. Students may not be interested, and sometimes even the staff is not interested in teaching. Now, that is a sad state of affair. There are some undesirable trends like overemphasis on aesthetic benefits at the cost of function and health aspects. Are we changing ourselves to be more like cosmetic treatment doers, or are we medical professionals? That we have to think. We must give great importance to function and health, and then comes aesthetics. That is my personal view. This is partly responsible for inroads into our field by general dentists, aesthetic dentists, prosthodontists, maxillofacial surgeons. They say if yours is a specialty which is meant for aesthetic dentistry, then we are also aesthetic dentists. We are equally competent. They are making inroads in our practice. Even worse, the commercial interests have joined the fray, and you have seen how the advertising has been going on, and I'm very happy that our society has taken a stand against it and has tried to stop those things. Now, the bada gum is in dental education. Is it in the pink of health? Cost of education has become prohibitive. Teaching staff often is not adequate, dedicated, or sometimes they don't have the integrity. Availability of patients is much less than what is desirable. Library facilities are meager at many places. There is interference from the management and pressure from the management that you have to pass all these students, whatever may be their standard, which is not a good thing. And because of that, the motivation level of the students also has gone down. Quality of research and publications, as I mentioned, at some places is very good, but other places it is deplorable. This was the cover page of Outlook magazine some years back, degrees for sale, and it may apply to some of the dental colleges as well, which is not a good thing. And the consequences are because we are overproducing substandard orthodontists, and because the employment opportunities are scarce, starting the practice is becoming prohibitively expensive, and it is all leading to desperation amongst the fresh pass-outs. Pressure of generating income by hook or by crook is affecting our standard and our moral values. Ethical practice has taken a severe beating, and genesis of the problem is sabse bada rupaiya, that rupaiya has become the main goal of treatment instead of doing good to the patients, which I don't think is the right thing. There are many ugly heads of the monster of unethical practice, such as overcharging, wrong treatment, unnecessary treatment, attempting treatment without the required expertise, hurried treatment, advertising, and so on. So that's rather a bleak picture. But what is the future? Which way are we going to travel? Now, what I feel is that there is a brighter side and there is a darker side. The brighter side is that technological advances leading to better diagnosis, materials and techniques will help us. Better and more precisely built appliances, surgical sprints, improved support from laboratories will help us. This was proposed many years back by Kusi, using of chemical agents in doing orthodontic treatment, which as of now has not materialized, but I don't know whether it will be possible in future. And genetic engineering, how far it will apply to orthodontics, I'm not very sure. The bleak side is there are problems which will aggravate in future. The cutthroat competition is going to become even more severe. There will be competition from corporate practices. You have to either update or perish. There is attrition of employees. Retaining good employees has become a real hassle, as I understand. Malpractice litigations are going to increase. So, this is where we stand. That's the legacy that we have carried so far, and this is where we stand now. And the question is, what legacy you are going to carry forward to the next generation? Now, that is what you have to think, and this is my advice to the young orthodontists. Study well, keep on learning lifelong. After you have done your MDS, your education is not over. You are a student lifelong. That should be your motto. Do not be afraid to start practice in smaller places. Do not think only of metro cities. Go to taluka places. That is where you can build your practice. Educate the masses, it is our obligation. And education could be from very small things, like that display there. केवल सीमा पर जाकर गोली खाना ही देश सेवा नहीं है. अगर गुटखा खाकर हर जगह थूकना छोड़ दो तो भी देश पर बहुत बड़ा एहसान होगा. So small things, but that is how you can treat the people. So my advice to the younger generation is strike a balance amongst various aspects such as work. Work is important, but also is important your family, your health, your friends, and the society in which you live. Money is important, but do not let it dictate your life. Life is much more than running after money and luxuries. Engage in ethical practice. So what ethical practice is, I'll show you with this small clip. Please listen to that. It's not audible, so I'll...
तो वहाँ पर हॉल में एक केस प्रेजेंट हो रहा था जिसमें ये पूछा गया कि ये स्पाइन का फ्रैक्चर है, पोस्टीरियर एलिमेंट्स का फ्रैक्चर है, तो इसमें आप क्या करना चाहेंगे। 96% ऑफ द ऑडियंस ने वोट किया कि हम इस पेशेंट को ऑपरेट करेंगे। तो जो केस प्रेजेंट कर रहे थे उन्होंने वो सवाल बदला कि अगर ये एक्सरे या स्कैन आपकी वाइफ का है तो आपका ओपिनियन क्या है, क्या हम इसको ऐसे ही ठीक कर सकते हैं या ऑपरेशन की ज़रूरत है। तो ये पाया गया कि वोटिंग जो सर्जरी के लिए पहले 96% थी वो गिर कर पहुंची 36% तक। जो केस प्रेजेंट कर रहे थे उन्होंने फिर सवाल बदला कि अगर मान लीजिए ये आपके खुद का एक्सरे है या स्कैन है तो आप क्या चाहेंगे अपने लिए कि आप इसको ऑपरेट करवाएंगे या सर्जरी कराएंगे या ऐसे ही ठीक कराएंगे। तो वोटिंग फिर से हुई और वोट गिरकर फिर से 4% पे आकर रुका। तो दूसरे को ऑपरेशन करना है तो 96% केसेस में करना है, खुद का ऑपरेशन करना है तो 4% केसेस में करना है। मेरा हमेशा से मानना रहा है कि मरीज का वो इलाज करके देना चाहिए जो हमें एक सर्जन को जो खुद के लिए वो चाहेगा कि अगर उसको वही फ्रैक्चर है या वही डिजीज है तो वही मरीज को करके देना चाहिए, तभी मरीज के साथ इंसाफ होता है। थैंक यू।
So, ethical practice will be that practice which you would render to your own children or to the children of your relations or nearby. When a patient comes to you, think of the child as your own child and do the best treatment as you would be doing for your own children. Maharshi Vyasa, at the end of Mahabharata, he has mentioned this. Artha means money or wealth, and kama means the desires. They should be within the framework of dharma. Dharma is duty. So, your urge to earn money and satisfy your desires should be within the limits of dharma and not crossing the limits of dharma. And if you do that, then that gives you moksha or salvation. Salvation is nothing but your mental peace. That sublime feeling of mental peace, that is the salvation. Now, although the theme of the conference is emerging new technologies, I thought that new technologies also must be based on ethics. And that comes only when you review your legacy, the way you have progressed. And then you have to decide how you are going to go ahead in future and what legacy you are going to leave to the next generations. And that's how I have presented my talk in a different manner without any reference to the not much of a reference to the technologies. I thank you for a patient hearing. Thank you all very much, and may God bless you.
Thank you very much, sir. Will you be willing to take a few questions, sir? Although it is not customary to offer questions to the audience in such lectures, but I take this privilege of offering the audience. The professor is willing to take on a few questions and comments, if any. I think, sir, there are none. Thank you very much for taking us through the journey of Indian orthodontics. Truly, it has been Indian orthodontics ka Amrit Mahotsav. Your lecture has been so. And the journey and the growth of Indian orthodontics truly reflects not Indian orthodontics, but also reflects the great Indian growth story. Your thoughts on the current position and ethics is forcing us to collectively introspect, and I'm sure the Gen Next will stand up to it and make a course correction somewhere, and we'll make you feel proud, sir. This I can assure you as a growing Indian nation. And once again, sir, thank you. And as is customary, I request the audience to please offer our appreciation in the form of a standing ovation.
Sorry?
Could you head over to the stage area so they could give you a token of appreciation? I would like to invite the chairpersons to present a token of appreciation to Dr. Jayde. I would now like to invite to the stage Dr. Girish Karandikar to present our chairpersons, Major General Balakrishna Jayan and Dr. Sandesh Pai, with a certificate of appreciation. Our next session for the day features another prominent figure in our field, Dr. Jyothindra Kumar. I would like to call on stage Dr. Vinaya Pai and Dr. Rakesh Malhotra, our chairpersons for this session. Dr. Vinaya Pai is currently a professor and principal at the Department of Orthodontics and Dentofacial Orthopedics at Bangalore Institute of Dental Sciences and Hospital with 25 years of teaching experience. Dr. Rakesh Malhotra is a senior orthodontist with over 40 years of experience. He completed his BDS and MDS from the prestigious King George Medical Institute and went on to teach at the same institute and PGI Chandigarh, following which he's a full-time practitioner since 1984. I would like to invite the chairpersons to introduce our speaker for the session.
A very good morning to one and all present in this hall today. It gives me immense pleasure, and I consider it personally as a great honor to be introducing our next legacy lecture speaker for the day. A man who needs no introduction actually, a name that is very well known and very familiar to all of us. I am talking of none other than Dr. K. Jyothindra Kumar, sir. Personally, I consider it a privilege, as Dr. Jyothindra Kumar, sir, was one of my examiners in Nair Dental long back in 1994. So it's indeed a great honor to introduce sir today. Dr. Jyothindra Kumar, sir, has completed his dental and orthodontic specialty qualification from the University of Kerala. Sir also holds an M.Orth from the Royal College of Surgeons, Edinburgh, and also the Royal College of Surgeons of Glasgow. Sir is also a diplomate of the Indian Board of Orthodontics. Sir has a fellowship in dentistry from the Royal College of Surgeons of Edinburgh and also the prestigious degree of Doctor of Science. Sir has retired as the Joint Director General of Medical Education, Government of Kerala. Sir has also been the past chairman of the Indian Board of Orthodontics, past president, Indian Orthodontic Society, past editor, Indian Orthodontic Society, a teacher, an administrator, author, speaker, and in Sir's own words, a lifelong student of orthodontics. Sir has won the best clinical paper, scientific paper of the Indian Orthodontic Society for a record 6 times. It is indeed a big privilege for both of us, sir, to have you here to deliver your legacy lecture, a true legend and a living encyclopedia of orthodontics. I proudly present to all Dr. K. Jyothindra Kumar, sir.
Very good morning to all of you. I hope I am audible at the back. Audible? Fine. Chairpersons, Dr. Vinaya Pai, my good friend Dr. Rakesh Malhotra, esteemed seniors, Dr. Jayde, Dr. Surendra Shetty, Dr. Sadashiva Shetty, Dr. Girish Karandika, all my good friends, senior colleagues, ladies, gentlemen, students, friends. It is indeed an honor to stand before you this morning and to have been invited to make this presentation. So may I say thank you to Dr. Akshay Shetty, I don't know if he's around here, and his team for having chosen me as one of the heritage lecturers. I also take this opportunity to thank the Indian Orthodontic Society, the presidents and the management committee from year to year. I have been a speaker on and off for the last 45 years, which I consider it a great honor. And I thank the Indian Orthodontic Society for giving me a forum to present my work through the years. Friends, as we are running late, I'll come to the subject direct. I was feeling a little nostalgic after listening to Dr. Jayde and the evolution of orthodontics. Although I cannot claim as much as seniority as him, I had the privilege of seeing the change in Indian orthodontics for the last 45 years, having entered the profession way back in '79. Friends, you will agree with me that orthodontics has become the first specialty in dentistry in 1900 and the third specialty in medicine after ophthalmology and ENT. The status of a specialty has been elevated and the practice of orthodontics has risen to a new standard of excellence with the specialty board which was introduced in 1929. The history of orthodontics closely follows the scientific progress made in anatomy, histology, and in material sciences. And it is remarkable that even after 125 years, we witness the coexistence of art and science and orthodontics, aesthetics and technology living together in harmony. Friends, art, science and biology have collaborated to advance the specialty of orthodontics and offer patients the best of both the worlds in the world. From 1950 onwards, technology has added as an equal measure or a partner to biology. Combined, one challenged the other to advance and improve the specialty for the benefit of our patients. It is important to recognize the scientific inquisitiveness of our founding fathers and the entrepreneurship that triggered the specialty progress that we are experiencing today. At this juncture, I think I should pay some respect to the scientific curiosity that has driven us, the specialty of orthodontics, since the time of Dr. Edward Hartley Angle, which has flourished in the 20th and 21st century. From the empirical observations to scientific discoveries, orthodontics has demonstrated that it is a field of study that is dynamic, ever improving to offer better treatment to our patients in a professional environment. Friends, there have been many technologies that has affected our life, but if you look back, in the last 30 to 40 years, even in our country, India, if you name the most important technology which has affected our life, there is no doubt that computers and computing, including the whole gamut of network computing, PCs, laptop, internet, broadband, mobile phones, email, all of them have in a way contributed to the quality of our life, and it has also impacted both dentistry as well as medicine and orthodontics in particular. And that march has been made possible by the remarkable advances in computer technology, starting with one transistor way back in 1950. Today we sat at 56 billion transistors which are packed, and it is never ending. The newer and newer generations of Intel processors are being made, of Apple chips, M4 are being made, and computers are put to diverse applications as we see it in day-to-day life. I'm a great fan of Dr. Albert Einstein, and he rightly said that the true sign of intelligence is not knowledge, but imagination. And I dare say that we orthodontists and the orthodontic profession has been very imaginative, and all the progress that we see is due to this quality. And he also said, don't listen to the person who has the answers. Listen to the person who has the question. And in orthodontics, we keep posing these questions from time to time, and this is the main reason that we have been able to go forward. Friends, as we stand today, as I look back from the time I entered the profession, way back in 1979, we had to pinch the bands. As Dr. Jayde said, we had to put separators. And I had the good fortune to see the transformation to direct bonding. There were no computers at that time. As PG students, we had to hand write all the articles for the seminars that we had to take. We have come a far, far way. When I look at clinical practice today, surface scanning or intraoral scanning has changed the traditional impression taking process. Volume scanning inventions have enabled three-dimensional technology from two-dimensional X-rays to CBCT. Computer-aided design software has allowed the design of custom appliances. Computer-aided manufacture has enabled the manufacturing of 3D devices, additive manufacturing, subtractive manufacturing, so on and so forth. It's now possible to make complex geometric objects in a variety of shape, in a variety of materials. Artificial intelligence is knocking at our door and has helped several procedures to become automated. Novel resins are being developed, which has made 3D printing possible and for numerous applications. Robotics and robots are knocking at our door, and it shouldn't be long before we find applications of robotics in orthodontics. And all these technologies synergistically are pushing orthodontic practices into a more and more digital direction. The three-dimensional technologies have enabled the shift from analog to digital. And as a result, the clinical practice is shifting to virtual-based workflows, and a new discipline in dentistry has emerged, which is loosely coined digital dentistry. And in orthodontics, for the want of a better word, we are using the term digital orthodontics. It entails, although it is very easily said digital orthodontics, it entails a very steep learning curve. It requires a lot of dedication, passion to pursue it and bring it up to a clinical level of perfection. And of course, in a country like India, there are severe financial concerns because the cost is on the higher side. Its jargon has become the buzzword today. In all meetings, when we meet friends, we hear a lot of buzzwords from digital orthodontics, and they have synonymous with progress and what is considered state of the art. Otherwise, you become a Ripple and Winkle in orthodontics. Combining the output of the digital modalities, we have the concept of the virtual orthodontic patient. The impact of digital orthodontics has been tremendous. I do not know if you have really appreciated it because we seldom get a chance to reflect on each of them individually. And my objective here is to just tell you the reach and scope of digital orthodontics. For sake of convenience, as a old teacher, I've classified it into 4 major headings. First is diagnostic imagology, patient data analysis, and in this, I'll just briefly touch upon the areas which are transforming orthodontics from the last 30, 40 years. Digital photography came into being in around 2000, and I made a prediction that traditional photography will be gone when I took the first PG convention lecture. And today I will say that digital photography is slowly vanishing, and it will be replaced by 3D facial scanning, which has with 3D, 6 degrees of freedom, and a vast amount of information significantly higher than that of photographs. Intraoral scanning has practically replaced our impression taking procedures. Digital study models have replaced the venerable study models. CBCT is practically replacing cephalogram and the orthopantomogram, and MRI and ultrasound are finding increasing applications. As far as patient data analysis is concerned, the big toy that we have been having is cephalometrics. 2D has progressed to 3D, but 3D has not really taken off the way we would have liked it to. CBCT evaluation has now become a new art in interpretation of radiography. Segmentation is a new approach to understanding microanatomy, to look at the various dimensions of anatomy. And fusion software is bringing technology together, the intraoral scan, the CBCT, the facial scan, and artificial intelligence is making it streamlined. And airway analysis is gaining significant inroads into diagnosis and treatment planning. And what we earlier used to give lip service was functional analysis is becoming more definitive with speech analysis, smile analysis, velopharyngeal function, and the like. And you also find significant changes in orthodontic treatment planning. Gone are the days of Kessling setup. Digital virtual setups have replaced it. Smile design has become a big subject, not only for the aesthetic dentist, but for the orthodontist as well. Surgical treatment planning in itself is a science. Growth prediction is still around because we still have to understand how humans grow and mature. Maturation evaluation software has therefore taken place. Practice management possibly is the most impacted among the lot. Practice management software and paperless office is order of the day. Patient education software has come in a big way. Patient communication software has really improved. Specialist and ancillary training is now done through the Zoom meetings. Specialist and ancillary upgradation is also possible through remote control methods. Appliance monitoring, even aligners, patient compliance still remains with us as a problem, and appliance monitoring is another area that we have been going through. Appliance fabrication and computer-aided manufacture, the whole gamut of 3D printing application has opened up a new Pandora's box. We have always had this fascination of custom orthodontic brackets, and fabrication software has come in a big way. Custom metallic appliance fabrication, the Marpace, the Sarpace, and you can literally design and print, including metal, on your desktop. Aligner design and printing has become a good science. Some people call it alinology. Whatever it be, it has come in a big way. And robotics is going to be the next big entry, including archwire fabrication, as well as robotics in many of the day-to-day procedures, custom CAD/CAM retainers. And lastly, there is a big group of mobile appliances which has made life easier. Admittedly, as you can see, this is a vast panorama, and in the short 45 minutes that has been allotted to me, I'll not be able to do justice. So the ones that I've highlighted in blue are the ones that I'm going to quickly touch upon. And just to give you an idea of the magnitude of digital orthodontics, it is estimated that in 24 it is 8.45 billion, and by 2022 it is expected to jump to $44.81 billion. And digital orthodontic market in the United States is estimated at 8,095 million, and it is expected to jump to 14,120 by 2030, which is increasing at a CAGR of 9.7%. And this is the current concept of an orthodontist office, fully digitally enabled. And among the young group of researchers, Dr. Niorcho Spanai from Egypt has been an excellent researcher, and I love his quotations. And he said, a fully digital orthodontic office includes the use of software that gathers and analyzes all digital input taken on cone beam CT, an intraoral scanner, possibly a face scanner, CAD software, and 3D printers. Intraoral and face records are also input into the software to create the virtual patient. In contrast to the traditional way in which all records, study models, cephalograms, panoramic X-rays cannot be gathered and evaluated as a single patient file. So that's the advantage of digital orthodontics. You have diverse sources of input, but they all are treated as one file. And you may be wondering what this picture is. I used the artificial intelligence DALL-E 3 to create an impressionistic view of an futuristic orthodontic office, and this is what DALL-E 3 came up with, how the future orthodontic office, that's artificial intelligence working for you, giving you a peek into the future of the orthodontic office. So the contemporary digital orthodontic office has hardware and software which forms its basis. CAD software enables orthodontists to practically design all appliances in-house. The scanners, both intraoral and extraoral, are tools of data acquisition. 3D printers are the output tools, and robots are being added to the whole list. So the sum total of the process of all these digital tools is what is called orthodontic workflow. And it has economy of time and money at its essence. So Kuna et al. In a nice article stated that even with all the benefits arising from digital workflow, few orthodontists have adopted this technique in their clinical practice, mostly due to the high cost and lack of technical preparation for proper execution. As we talk today, it is estimated that even in the United States, the penetration of digital orthodontics is between 50 and 56%. And in India, I would put it somewhere between 30 to 40% as some sort of a estimate. The purpose of my talk is to sensitize my fraternal colleagues that digital orthodontics is impacting our professional practice in a big way, and to just sensitize you on this emerging scenario. So I thought a good point to start off will be intraoral scanning in digital orthodontics. All scanners work the same way in scanning an object which is reflected and recorded as separate image or videos. In the last couple of years, the number of scanners that are available in the market has really multiplied, and there are about 45 brands which I could count which are available in India alone, costing anything from about 3 lakh rupees to about 36 lakh rupees. So for over 150 years, plaster study models have been the basic pillars of diagnosis and treatment planning in orthodontics. It was the gold standard of obtaining conventional impressions is the use of elastomeric materials in custom trays. The first in-house commercial digital scan systems came into the market in 2008. And since then, in the last hardly 16 or 17 years, it has captured the imagination of the profession, and it has captured practice in a very big way. So the biggest area of impact in digital orthodontics is undoubtedly intraoral scanning. The amalgamation and integration of the intraoral scanner with orthodontics is progressing at a rapid pace. The clinical aspects of intraoral scanner depends on its features such as accuracy, reproducibility, scanning time, patient comfort, and operator experience. I did a search for this presentation, and I came up with from PubMed, there were almost 3,556 articles that have been published in the last 7 to 8 years on digital scanners. So you can see how voluminous it is, and the material is all there for you to find out. So I'm not going to waste any time, but just talk upon 5 important aspects of scanner. Today we think that digital is terribly accurate, but sadly, if you read the literature, you will see that you can cite from the literature many articles which even say that plaster models are marginally better than digital models. You can also see the recent articles which say that digital scanners are far more accurate and far more time saving. So the whole problem is that it is like a secret in plain sight. We do not have industry standard for scanners. We have had this problem with the video recorders we had once upon a time. The industry has not really come together. They have not prescribed standards. They have not defined reproducibility. They have not defined accuracy. So it is for the clinician to decide for himself what would be accurate for the purpose. And today, the general figure that people talk about is 50 microns is supposed to be accurate enough. I would say that 30 microns is a good figure considering the future developments that are taking place. And there has also been a lot of debate on is scanning time more or the time that I take to take an impression and pour a model which is shorter. And this debate still rages on. And there are a lot of people who say if I had the digital scanner up and working, I can print you from the scan to a digital model in 8 minutes flat. So that is what they would say. But a good seasoned clinician will say, it'll take me 2 minutes to take an impression, and it'll take me 2 minutes to pour an impression, and I can have the model ready in 45 minutes flat. So I leave it to you to decide which of them is better. But there is one area where there is no ambiguity at all in that everybody agrees that the anorexia, the retching, the vomiting that you have with an impression is completely gone. Patient comfort is definitely better. Patients are able to breathe, smell, taste, and the gag reflex is very effectively controlled in digital scanning. The operator experience is important. There are a lot of my friends who thought that if I buy a scanner today, I can put it into operation tomorrow and produce standard results. Well, nothing could be farther from the truth. It needs a tough grind to use, and even if you have more than a scanner in your practice, when you switch scanners, it's like switching a car. It needs a lot of finesse to understand the working of the scanner to your convenience. And once the learning curve is established, IOS may confer significant clinical advantages, which is well documented. Orthodontists also say that today digital is a brand value. So if you have a scanner in your practice, it adds to the brand value of your clinic, and you are said to be up with the times. I just wanted to make a couple of comments on intraoral scanning. The biggest advantage, obviously, is that for those people who want to do in-house, there have been a lot of pre-conference courses suggesting in-house, but it's also equally convenient to work with laboratories by sending off this data. It saves considerable amount of time and money on consumables every year. And the use of intraoral scan can be complex and perplexing in the beginning, but however, once you master the learning curve, the handling of the scanner and software becomes fun and easy. And I can say that after about 18 months of use, I'm starting to enjoy to use the scanner. In the beginning, it was horror. It was difficult getting into spaces. It would take me 8 to 10 minutes to get a scan. But after this long, I've been able to do it in 2 minutes flat. So the cost of purchasing and managing an intraoral scanner may be excessively high for individuals and new practitioners. In India, I think we must consider this, but the plus side is many of the laboratories are offering scanning as a free service. There are also independent roving type of scanning available, so that is easing up. The useful applications in orthodontics are in diagnosis and treatment planning, but I doubt whether as orthodontists we are really tapping into the amount or volume of information that is generated by a scanner. Its immediate access, reduced storage space, and intercommunication are the main benefits. Intraoral scanners provide the orthodontist with numerous applications, which used to take me several minutes or if not hour in generating, especially the arch form, the arch width, the tooth size, the transverse dimensions, Bolton discrepancy, overjet, overbite, arch form, occlusal contacts. All this can be rapidly generated. Plus the additional benefit of using diagnostic setup is also very attractive. Now this is a software which I regularly use, and once I scan it, I put it in, it makes a model base for me, and then it gives me all the data, including odontometric data in every fine aspect. Cervico-incisal length, labiolingual thickness, the rotation, the crowding, all this can be obtained in a jiffy with application. There are a number of softwares that are available, but my recommendation is to use DD Ortho, which is comfortable, and you can actually, before putting on your appliance, put it on from a bank of orthodontic appliances that they have. I believe they have virtually all the prescriptions that are in the market. You can put them on, you can look at the FACC point, you can look at the interferences, you can look at the arch, the curve of Spee, where you need intrusion, and many things can be eyeballed. And one special advantage is selecting the arch wire that would be appropriate, because it will give you the nice arch form, and selection of the arch form is no more a guesswork. And it gives you an occlusal map, so especially in TMJ cases, it gives you a good idea. And there's a lot of new technology coming in. Even from your photograph, there's an automatic thing in WebCef where you can generate your Bolton, you can look at the arch configuration, match it with your alveolar bone base, and plan your treatment based upon that. And what used to take us several hours, I still used to shudder when my former professor used to call me and say, Jyothi, please prepare a Kessling setup for this and have it ready when the patient comes next time. So this Kessling setup used to occupy a lot of our time and effort, which has actually become very simple, which I'll try to show you. Please watch this video. It's very simple. You don't have to do any more setup. 3 standard procedures that we do: non-extraction, 4-4 extraction, and 5-5 extraction are very easily stimulated. I'm sorry. I'll try to play this video. I think you can watch that. This is a free online software. So I use this a lot of time. So my decision whether it's a premolar extraction, non-extraction, or a second premolar extraction is matter of couple of seconds. And we always had this doubt whether to do IPR or not. And if you look at this, it shows you the IPR, how much is possible. which tooth is to be extracted. You get a preview. So this is what diagnosis and treatment planning has come to. In a jiffy, you can do a lot of things using computer technology. And I made a prediction that dental photography, digital photography, if you know it today, is going to be replaced completely in the next couple of years. And 3D facial imaging has been one of the largest areas of impact. So in the center, you have imaging technology, and you have a whole gamut of technologies within that. One is laser-based scanning. It has slowly fallen by the wayside. The integrated CBCT, I've put it on top because that is where the profession is going to go. And you have the smartphone, which is making life easy for us. A lot of applications can be run on the smartphone. 4D imaging is coming in a big way because of sensor technology, because of computing power. 4D imaging and analysis of dynamic movements are coming in a big way. And what has really made the current change to 3D possible are the RGB sensors. Then there is structured lighting, which is used in the intraoral scanners, and stereophotogrammetry, which is used on a day-to-day basis. As practitioners, we are all interested to know where and when each of these technologies need to be used. CBCT, I've given the indication in red because of the high cost, the magnitude of radiation that it produces. Mind you, these are traditional data going up from 11 to 674 millisieverts, and for maxillofacial radiology from 29 to over 1,000 millisieverts. You will see that it has come down significantly. MRI is again limited selectively to selective applications. Stereophotogrammetry, affordable, non-invasive, may be recommended in every case. Laser scanner, non-invasive, recommended in every case. Intraoral scanner, it is again non-invasive, recommended in every case. Extraoral scanner, affordable, non-invasive, may be recommended in every case. So the advantages of technologies of facial imaging is that the surface scan systems are non-invasive, and therefore repeat images are not an ethical concern, especially in cleft lip and palate, longitudinal modeling of facial deformities. Once the scan has been made, the operator and the information of facial structures, material can be used repeatedly and by different observers. The images may be stored in soft forms or digital forms on-site or in the cloud, and subsequent archiving is much more practical, and extra space needed for physical storage is obviated. The development of software program enables to precisely and reliably analyze the 3D data. Digital tools such as zooming, rotation function in the software programs, which are user-friendly, adds a new dimension to evaluation. Infrastructure requirements, just a word about it. The older 3D surface imaging systems are bigger, bulkier, expensive. They are giving way to emerging devices which are portable, even the smartphone, and are compatible without additional equipment. The higher-end systems sometimes are useful, and diagnostic centers offering a service, as we do with CBCT, is perhaps in order. So this has to be kept in mind while deciding what is appropriate. I just want to take a minute talking to you about stereophotogrammetry, because this is a technology that is widely used for facial scanning. Time does not permit me to go into the details, but the biggest advantage is that it has a short acquisition time and is friendly with pediatric patients. It can be combined with CBCT images, and the images can be viewed on a personal computer and used as a communication tool. And it's useful, and you can readily make, because earlier we were obsessed with hard tissue images and measurements. Now it is possible in equal measure with soft tissues. Area and volume can be very readily measured with this technique. For example, here you can measure the volume of that and see the pre and post changes. You can move parts of it by using algorithms and use it effectively for simulation. And what has really made this possible is the availability of RGD sensors, which is a technology that has been developed by Intel Corporation. And RGB have developed a group of sensors called time-of-flight sensors, which projects infrared points onto a subject's face, and the time taken for the wave to reflect and reach the scanner sensor determines the point distance, and the 3D image can be generated. And RGB sensors have been developing. So this is the size of the RGB sensor in comparison to a golf ball. There are many of them very cheap, and it has made facial scanning as well as 3D facial image acquisition practically a simple procedure. So based on this, we have number of facial scanners which are available. Accu3D, it's not available in India yet, but it's one of the better scanners which can readily give you a lot of soft tissue parameters. You can look at facial symmetry, you can look at the relationships, measure the angles, degrees, and it is all done in a jiffy. In fact, a number of cost-effective scanners are coming in the market. Another one that comes from Italy, which costs typically less than $1,000, is OBI scanner. And Shining 3D has its own version of the new MetiSmile, which has come in. It gives you fairly good scans. But there are also other hybrid philosophies which are in the market. One is Rayface, which comes from Korea, and the other is CareStream. Rayface is actually very good. It gives you a set of pictures in a matter of seconds, and you get 3 images of the same patient in one view. The 9 image sensors operate simultaneously, but Ray is slightly high priced, and it's possible to integrate with the Ray scanner, the CBCT. All this can be fused into one panel, wherein the intraoral scan, the CBCT, and the facial scan merge together, an area called Fusion software. But I personally feel that in the Indian market, we are probably the best one that is available, where all this is built into one, is the Kodak CareStream 9600. It has got an OPG, it has got CBCT, it has got a facial scan, and all this can be integrated together to produce one single output. And the best part of it is it produces ultra low dose radiation, and we will come to the recommendation in a short while. And in the recent past, that means in the immediate past 5 years, a number of hand scanners have come into the market at very low prices, between $700 to $1,000, which can give you excellent results for practical use. I've started using them, and these sort of scanners, which are mounted on tripods, give you excellent pictures. They can supplement digital photography, or they can be standalone, because they can be pulled into your digital smile analysis. It can be used for a number of applications. This is the standard setup that I use in my practice. All patients get a facial scan along with digital photographs, and the scans that I get out of it are very useful for day-to-day applications. Now, there's one interesting thing that I want to bring to your notice, is that in cephalometrics, we have always had the problem of head orientation and the Frankfurt horizontal plane, and to maintain the angle properly. And this study, this was a doubt which I also had in my mind, and this study clearly shows that precision is not altered by the rotation of the head when you do a facial scan in 3 planes of space, making the acquisition process even simpler and less constrained to a predetermined position. It improves the comparison of acquisitions at different times and conditions, facilitating the clinician during long-term treatment. This has been one problem that has been bogging us, whether it is clinical photography or whether it is cephalometry. The head position makes a lot of error in our findings, and with 3D scanning, this is actually taken away in big way. So I just want to talk to you about the impact of CBCT in orthodontics. Today, in my practice, practically you may think it is outrageous, but most of the patients, I would say 80% of the patients, I take a CBCT for clinical evaluation, and 20% is traditional CEF and OPG. And why I do that, I'll explain to you in a minute. Cone beam CBCT has revolutionized the field of orthodontics by being able to provide 3-dimensional data, high-resolution images of the oral and maxillofacial structures. It offers a comprehensive view of teeth, bone, nerve pathways, and soft tissues, enabling the orthodontist to accurately diagnose and plan dental treatments. CBCT produces volumetric data, what we call voxel volume, and comprehensive 3D analysis of the structures are possible. And today, what is even more attractive is, I do not know if you have read the current recommendations of the European Maxillofacial Radiology Society. In fact, they have made a historical recommendation to all professions in dentistry, specialties in dentistry, that you stop taking CEF and OPG. It may sound outrageous when you listen to it in the first place. I was also shocked when I read this recommendation. It came out in February. They are saying that the new machines, not all of them, but at least most of them, and they have mandated that in 5 years, that world over, everybody should change over to the single ultra low dose and low dose CBCT. So a traditional panoramic X-ray plus a lateral ceph was giving you 26.9 millisieverts. The overall effective dose of a CBCT was 132 to 200 millisieverts. It is low enough, but with the new single low dose CBCT, you are able to get a 3D CT picture for 11 to 18 millisieverts. Far, far lesser than what you would be getting for a traditional Ceph and OPG. In fact, they recommend that you don't take a separate Ceph OPG, but you can extract a Ceph and OPG from a CBCT using the software that is supplied. So this shows the validating studies that have been published, and they have recommended. CBCT was supposed to be a no-no, especially for longitudinal growth monitoring. So if you had a cleft patient and you had to do CBCTs over and over again, we were told that you should not do it. But today with the ULD protocol and the LD protocol, I see no reason why we should not use it in a sequential basis. And these pictures I put on particularly to show that the image quality has not in any way suffered because of the low radiation dose. You can see that with this at 21 millisieverts, you can do an airway evaluation. You can do a routine orthodontic canine impaction evaluation for as low as 14 millisieverts, which is very, very economic, least to say. So the bottom line is that the LC compared to standard LC should be considered for routine diagnostic purposes. I have underlined that. I am aware that, having said that, it's not available in every city, but the next time that you have any say in the procurement of a new CBCT machine, you should go for one of the low dose CBCT machines, because that is where the future is. And another thing that has come into the fore in the last 2-3 years, which I find it very, very useful on a day-to-day basis for orthodontic diagnosis and treatment planning, is in tooth segmentation. There are no doubt specific applications such as canine impaction, but 3D segmentation allows a detailed volume and position evaluation of the teeth, their roots, and tooth segmentation is invaluable in guiding orthognathic surgery as well as in implants, especially the placement of TADs. It is having a significant impact. So much so that this is one of my canine impaction cases. This is a bilaterally impacted canine, and I've done the tooth segmentation. And of course, all measurements can be done very easily on a CBCT, so I've not included that. But eyeballing of the location gives the surgeon a lot of leeway in treatment planning. And having said all this, there's also another emerging area where we are seeing what is called image fusion, because the image is coming from disparate sources. You have the intraoral scanner, which will give you the clinical crowns and odontometric data of teeth. You have the CBCT, which gives you the bone and teeth. You also have the facial scan, which gives you the soft tissue. And putting all these three together is the challenge. And artificial intelligence using deep dental multimodal fusion technology is becoming very common. Liu has proposed a new method. It's very good, and you can get accuracy as low as 0.1 and 0.3 respectively. So this is one of that. You get the intraoral scan, the CBCT, and you can put them together and fit the dentures, upper denture from a scan with that of the patient, and you get a composite view or a virtual patient. And what is good is assisted intelligence technology is now used so that practically you don't have to calibrate any of the images. All the calibration is done automatically, and by fusing these imaging sources, a comprehensive 3D view of the underlying anatomy with clear visibility for enhanced treatment planning and presentation is possible. So AI is coming in a big way and doing it. And this is, I think, the most fascinating area in the whole of digital orthodontics. Earlier planning was only using the intraoral scan. You were looking only at the crowns. We were forgetting the roots, and sometimes the computer would imagine what the root looked like and added a root to it. But today we have the technology of virtual setup for both roots and alveolar bone. From the CBCT, you get perfect anatomical reproduction of the root morphology, the size, shape, disposition, the bone quality, so on and so forth. And from the intraoral scan, you have perfect data on this, and you can add all this together to produce what is called a virtual image. And I just want to caution the use of CBCT. I know there are many sleep medicine practitioners here, but in our place we see a lot of diagnostic decisions being taken on CBCT for future purposes. So I would say that as I'm running short of time, I'll go a little fast. The outlook of future development is very good. I just briefly touch upon 3D manufacturing. It has become a routine thing, and customized orthodontic brackets are a great attraction for orthodontists. Technology is now available, proof of concept has been shown, and there are now many systems in the market where you can make your own customized brackets. And CAD, what would the future orthodontic office look like? It has got CAD software, a high resolution printer, a choice of bracket resins, and an archware bending robot. It's soon joining. And when you use zirconia printers, you can even produce aesthetic brackets. And there's a wide variety of materials to choose from, and printing technologies: polyjet, multijet, fused deposition modeling, selective laser melting, SLA and DLP. You have photopolymers, plastics, AB, polypropylene, plastics, metals, photopolymers, so on and so forth. So 3D manufacturing in orthodontics is really going places. That in itself is probably a day or a 2-day course that summarizes all the technologies that we have used. And this summarizes the kind of materials that we have today for 3D printing. And I just wanted to show the zirconia printer, which has become desktop. You can practically print any of these materials that you require, including brackets, using zirconia. And there have been a number of in-house softwares that are now become available. And Delta Face is one, why I'll come to. And I just wanted to talk a little bit about direct printed aligners, which is a new wave in aligner orthodontics, because we all know the disadvantages of thermoformed aligners, and they do not do a good job. And direct printed aligners are coming in a big way, and there are a number of dedicated softwares which are now available in the market. Some of them are totally free. For example, Blue Sky is totally free. There are other softwares which are good, Maestro 3D. Most of your scanners come with some sort of a printer, and direct printed aligners is holding the market now. One of the biggest advantage is that the material that they use in Graphy is a memory polymer. There's a separate course on it, so I'm not going to spend much time on that. So direct printed aligners is the wave of the future. I just want to touch upon briefly artificial intelligence and its impact in orthodontic practice. We all know the different types of artificial intelligence mechanism. I just want to point out to you that I'll be finished in 5 minutes. Using the extraction decision, using artificial intelligence, you get an accuracy of 80%, 93%, and 93%. For evaluating maturation factors, you get an accuracy of 77%, and this is steadily increasing. You all know the impact of ChatGPT, which has had on our day-to-day practice. And treatment assessment, evaluation of third molars, accuracy 90%, 97.2%. So you practically cannot go wrong if you use it. Prediction for the need of orthognathic surgery, almost 0.97 to 0.99. Evaluating treatment outcomes, you get an accuracy of almost 97%. So just to show that artificial intelligence in classification of skeletal patterns, class 1, class 2, class 3, accuracy of 74%. Impacted canine diagnosis, looking at the maxillary width, all that, almost 90%. And automated landmark analysis is one of the areas which has really come into the being. And they use this YOLO 3, that is, you look only once. And from that, you are able to distinguish many of the structures that you see. And this is the last thing I wanted to talk, because this was one of the most difficult things to do practically. Because it's very easy to superimpose 2 intraoral scans. But if you actually wanted to measure it, it was difficult. And this was what I found recently. And with this technique of using artificial intelligence, you are able to measure the displacement in 3 dimensions accurately to 3 decimal places. Accurately to 3 decimal places. So for scientific evaluation for our research work, there's nothing better than this. And today we have a number of commercial-based CEF services which are available in the market. I could count as many as 30 of them, but my favorite is WebCEF. And what WebCEF can do for me, I think most of you will be using WebCEF in some form or the other. You just load your photographs, just load your facial scan and your CEF OPG, and it throws up a huge amount of information. You can, it summarizes everything for you, as many analyses as you want. In the last count, there were 54 analyses. I'm sure it will be too much of information. You can superimpose your facial scan, your picture, and do a lot of treatment planning in 2 dimensions or 3 dimensions. And lastly, before I conclude my presentation, I just want to share some philosophical questions with you. Martin Coburn from King's College London, a good friend of mine, he always used to say, nevertheless, one should stop and think if this technology leads to better patient care and treatment outcomes. We should always pause a little to think about why we are doing something rather than simply doing it just because we can. Friends, digital technology is faster than an eye could catch and faster than the orthodontic community can integrate. Obsolescence is today. In this technology rush, universities should align and incorporate this technology in their curriculum. As an old teacher, I am very doubtful that many of the programs do not even have fundamentals of computer and digital applications being taught to the students. And I make a fervent plea to all my colleague teachers that they should incorporate an element of digital in their postgraduate programs. And we should also ask the questions, does printing customized bands and designing appliances in software lead to better treatment? By and large, the answer is yes. In terms of accuracy, in terms of space, there is a learning curve involved, but yes. Moreover, does designing and manufacturing aligners in office create better outcomes? Again, my answer is yes. I was at the Graphy workshop yesterday, and it became again reinforced to me that in-house is the way to go. And is direct aligner printing better than traditional thermoforming aligners? We can debate about the merits. Do in-office customized brackets offer significant advantages to the orthodontist in performing better and faster treatment outcomes? All these questions have not been answered yet, leading to the necessity of conducting research studies to prove the superiority or the lack of it of digital technology over the traditional way of treatment. I would like to conclude by saying digital technology advancements will continuously change the practice of orthodontics. The new generation of orthodontists will certainly have to include this technological advancement in their offices. If you don't want to be, prepare to be called Rip Van Winkle. The trend and ability to create most orthodontic appliances using desktop machines and innovative new materials will continue to flourish. Unfortunately, companies and orthodontists are rushing to use new technology and materials, whereas little research has been performed to investigate possible hazards for the patient and to validate the efficiency in orthodontic treatment. I particularly want to alert you that as aligner users, one should be very, very alert about the material that we are putting in the patient's mouth. The first evidences are starting to come out that a lot of this plastic is entering the bloodstream, excreted in urine, excreted in sweat, and maybe we are on a ticking time bomb that anaphylactic reactions have already been reported, especially if you do not centrifuge the aligner and get the unpolymerized monomer out of your aligners. So this is an area which I would like to highlight. And artificial intelligence is a relatively new technology which will help in the analysis and understanding of various orthodontic treatment processes while providing treatment assistance to orthodontists, but I think that it will never replace orthodontics. Thank you very much for a patient hearing. Thank you very much.
Thank you so much, Professor Jyothindra Kumar, for a wonderful lecture and taking us through the importance of embracing digital technology. And as he rightly ended on a sober note, we have to embrace digital technology and artificial intelligence, but not at the cost of suppressing our natural intelligence. That should be supreme. Thank you so much. May I ask the audience for a standing ovation, please?
I would now like to invite Dr. Sadashiv Shetty, sir, to please present a certificate of appreciation to our chairpersons. Next up, we have the Indian Board of Orthodontics promotion by the chairman of the IBO, Dr. Raj Ganesh Gautam.
A warm good morning, ladies and gentlemen. I bring very fraternal greetings from the Indian Board of Orthodontics. Warm greetings from the Board of Directors, Team 2023-24. The Indian Board of Orthodontics, the specialty board of our Indian Orthodontic Society, was established on the premise that it would examine applicants, and if found proficient, the board would issue a certificate of excellence to those who meet the standards established by the board. I would say that IBO is an IOS commitment to the highest standards of orthodontic care. The objectives of the Indian Board of Orthodontics are to stimulate a spirit of self-improvement and to encourage continued professional review, elevation of standards of education and treatment throughout one's professional career. As Albert Ketchum rightly put it, its certificate of fitness has no legal standing, but is a powerful psychological factor in stimulating specialists to acquire increased knowledge and skill in their respective branches. Why board certification? The certification process itself requires the clinician to intensely review his or her orthodontic training, temper it with experience garnered over years of clinical practice, and challenge oneself to put to test his or her clinical expertise through a display of selected cases for assessment. So this is something that commits the clinician to a habit of delivering excellence, and if practiced consistently is definitely raising the standard of excellence in the practice of our specialty in our own country and the world at large. The Indian Board of Orthodontics Board Certification has three phases: the board applicant, the board eligible, and board certified. The applicant status is basically a credential check, and it automatically happens when you apply for the phase 2 exams. The phase 2 is a multiple choice based question exam which is now conducted online through centers span India and abroad. And phase 3 is a comprehensive clinical examination of 5 case reports as set by the standards required by the board. Now the eligibility criteria for the phase 2 online exam is any postgraduate resident who has completed 12 months, and in life members who have passed their MDS exam before 31st December 1998 are exempt from giving the phase 2 written exam and can directly take the phase 3 exam. And once you have taken the phase 2 exam, you can appear for phase 3 anytime. There is no validity as of now as per the present guidelines. The examination pattern again has been modified to be more practical. You know, we are looking at about a single paper of about 250 questions, 3-hour exams, which is taken as an online exam. We did it in 36 centers all around the country. There's no negative marking, 50% required for passing. And an interesting thing is, it can be taken abroad also by centers there, so you don't have to really come over to take the phase 2 exams to India. It can be done abroad also for our life members who are present outside and for international members after the proper processes. The next phase 2 exam is expected to be on the 19th of January 2025. I would request all of you to keep yourself updated at the board's website where all these details are mentioned. The phase 3 clinical exam consists of an oral examination and an evaluation of candidates' 5 case reports. There are 5 categories which are required as per specific directives, and they should be treated by the candidate himself. What would be the eligibility? You need to be, you cannot take the phase 3 exams within 5 years after receiving his or her postgraduate degree. And case reports of patients treated during the candidate's tenure as a resident again cannot be brought to this exam. There are 5 different categories. Category 1 is a class 1 with tooth material arch length discrepancy manifesting as crowding more than 5 millimeters. Category 2 is a skeletal class 2 where attempts at growth modulation have been done. Category 3 is a transverse or a vertical problem, whereas category 4 and 5 are cases of sufficient level of difficulty which is as per the candidate's choice. There's some notes, at least one of the above 5 cases should be a 4 premolar extraction case. Only one amongst them can be a surgical case. In order to help the candidates assess the difficulty level of category 4 and 5 cases, we have come up with the Indian Board of Orthodontics Index, which is in the process of validation and is very objective and helpful. Only one among the 5 cases as per present guidelines can be a case treated with clear aligners, and digital records, if presented, need to be considered supplemental to analog records at this present point in time. The board is open to modifications, but these are the present guidelines which are there. All these details are very well explained in our website, www.indianboardorthodontics.com, and I would encourage all of you to please go to the website and look into it. This is how the case evaluation sheet is. The IBO convocation, once you finish your exam, is truly a ceremonious event. We have one coming up today evening at 4 o'clock in Hall Oceana B. And then you get a very prestigious certificate. Now, in order to help the candidates take up the diplomate exams, we have even created a panel of mentors who are available, whose details are available on the website. I would again encourage all candidates aspiring to get board certified to please look up and take the help of other certified diplomates in their case selection and the processes involved. It's indeed a truly cherished moment in one's life. When are the next phase 3 exams? We recently had it yesterday and day before yesterday in Bangalore. For 2025 year, it will be conducted during the 59th Indian Orthodontic Conference to be held at Visakhapatnam. So today at 4 p.m., as I said, we have the convocation, the 25th convocation, which is again a very, very important milestone for the board. It's the Silver Jubilee convocation. I would extend a very warm welcome to all of you to be kindly present there and grace the occasion. And the 24-25 year is earmarked for a lot of celebrations for the board completing 25 years, and I'm sure all of you will be updated on all the details. The Indian Board of Orthodontics is also a part of the Society of Specialty Certifying Boards, SOSCB of the World Federation of Orthodontists, where we have been actively involved in their meetings. And the SOSCB is going to organize a meet of all the specialty boards at the 10th International Orthodontic Congress at Rio de Janeiro, Brazil in October 22 to 25, 2025. And I think many of the Indian contingent is going there, and we're going to have useful inputs coming up there. We are a very, very big society, the Indian Orthodontic Society, but we are a very, very small group as far as the Indian Board of Orthodontics is concerned. So I would encourage all of you to look at trying to take these exams. It's a very, very fulfilling experience, I can promise you. We are still a very small percentage, and the mission of the board is to encourage more and more of our members taking up the board certification process. It's important to set goals for yourself on an annual basis, but not too many. Certification by the Indian Board of Orthodontics could be a good goal. Preparing for IBO certification will probably be the best continuing education course you will ever take. Believe me, taking your boards may not make you a better orthodontist, it may not make you better than the orthodontist down the street, but I can promise you that it will surely make you better than you were before. So it's the clinician in you that has evolved. Concluding remarks, excellence is never an accident. It's always the result of high intention, sincere effort, and intelligent execution. It represents the wise choice of many alternatives. Choice, not chance, determines your destiny. Excellence is not a skill, it is an attitude, and most importantly, there is a substitute for hard work. So I'd like to conclude my talk with a very positive note that I wish to see more and more of our members getting board certified with the Indian Board of Orthodontics. Thank you so much.
Next, we have the very exciting session, the IOS Oration by Dr. Ashwin Matthew. I'd like to call upon stage the chairperson for the session, the very esteemed president of the Indian Orthodontic Society, our very own Dr. Jayesh Rahalkar. Dr. Jayesh Rahalkar completed his bachelor's degree and his master's degree from the Government Dental College, Mumbai in the year 1992 and the year 1996 respectively. He completed his M. Ortho in UK in 2004 and was awarded the FDS RCS in 2014 by the Royal College of Surgeons of Edinburgh, United Kingdom. He has been the director of the Indian Board of Orthodontics from the year 2014 to 2019. He was the former professor and head of the department, Dr. D.Y. Patil Dental College and Hospital, Pune. He has over 25 years of teaching experience, and he is, of course, currently the president of the Indian Orthodontic Society. While his list of accomplishments could go on and on, I'd like to invite Dr. Jayesh to please introduce our speaker for the next session.
Hello. Hello. Hello, am I audible? Indian Orthodontic Conference is basically for the exchange of scientific contents. We have the Rising Star lectures, the competitive and non-competitive category lectures, guest lectures, keynote lectures, and 3 very important oration. Indian Orthodontic Society oration is such very important part of the scientific deliberations of the Indian Orthodontic Conference. And this year, we have Dr. Ashwin Matthew George, who has been awarded with this particular oration. And I have pleasure in introducing a very good friend of mine, Dr. Ashwin Matthew George. He completed his post-graduation from Tamil Nadu Government Dental College, Chennai in 1996. He is currently a professor at Savita Dental College and Hospital in Chennai. He completed his National Board of Examination, that is DNB, and also he is the Diplomate of Indian Board of Orthodontics. He has recently completed his PhD on the role of ACTN3 and GHR genes in skeletal malocclusions from the reputed Savita University of Medical and Technical Sciences, Chennai. Dr. Ashwin has been awarded the best paper 3 times in the IOS national conferences at Jaipur, New Delhi and Cochin in both clinical and research category. He has presented scientific papers at World Federation of Orthodontists Conference, Sydney, Australia and the AEDC in Dubai. He has also published more than 50 scientific papers in both international and national peer-reviewed journals. Dr. Ashwin has held significant posts in the Indian Orthodontic Society as well. He had been the past chairman of the Indian Board of Orthodontics. He has been the vice president of Indian Orthodontic Society. He has been the convener of Madras Orthodontic Study Group. His areas of interest include self-ligation system, implants in orthodontics, genetic malocclusion. He was also the chairman of the treatment protocol for practitioners book, which was published by Indian Orthodontic Society in 2016. He has a lot of contribution to the IBO index as well. One of his passion is music. Music, singing and guitar are his passion. So I welcome here a very dear friend, a passionate teacher, musician at heart, very zealful clinician and a very hard-working member of Indian Orthodontic Society. So ladies and gentlemen, please put your hands together to welcome Dr. Ashwin.
Thank you, Dr. Jayesh Rahalkar, President, Indian Orthodontic Society, for that very eloquent and generous introduction about me. It's always good to have a good friend and a close associate say something good about you. And I hope I would remain true to your words. Good afternoon, ladies and gentlemen. I stand humbled at the opportunity given to me to deliver this oration lecture on behalf of the Indian Orthodontic Society, a vibrant society that has been very close to my heart and has kindled my passion to the art and science of orthodontics. I became a member of this society in the year 1996 with an LM number 677, and from then I've made many good friends. I see many of them sitting in the audience, and I will always remember the love and support you have given me. With that brief introduction,
I would like to start my presentation on the topic, the ligation versus self-ligation debate. The ligation versus self-ligation debate is synonymous with the extraction versus non-extraction debate. But there are many claims that the self-ligation system is superior to the ligation system. But there are more questions than answers to these claims. And I'm here to share my personal experience on how these different mechanics work. And I hope by the end of this presentation, I will leave you all with some more clarity. As we all know, orthodontic treatment depends on the interplay between the brackets and the arch wire. In the conventional system, the built-in features in the bracket could be triggered by the arch wire, and the bracket remained more as a passive component. But in the self-ligation system, a new idea was conceptualized where the bracket itself could play an active role in force transmission. And today, we are going to dwell into the various aspects of this self-ligation system, its advantages and limitations. Before I start my presentation, my due respects to the founding fathers of our society, 7 of them, and how they evolved the different techniques from the basic removable, functional, and to the fixed appliances. And I'm very proud to say as an Indian that orthodontics in our country has grown a long way since then. I was fortunate to be trained under some of the legends of Indian orthodontics. Most of the seniors sitting over here would surely recognize them. I graduated from the Tamil Nadu Government Dental College and Hospital in the year 1996. I was basically trained in the Beck's technique with a very small experience with a pre-adjusted edgewise system. During the early 90s, the straight wire bracket was not introduced into our department, and I vividly remember our professor, the late Dr. M.R. Balasubramanian, was kind enough to bring some of his straight wire brackets from his clinic just to encourage his students to get the feel of the new system before we left his department. I will always be grateful to my teachers. For any new system to be successful, it should be able to overcome the drawbacks and limitations of an existing system. Some of the limitations for the steel and elastomeric ligations are listed. But one limitation that is common to both groups and stands right on top of the list is friction. The self-ligation system was introduced mainly to handle this limitation of friction. So let's start with the basics of self-ligation brackets. Self-ligation brackets have a mechanical device into the bracket to close the slot. And this movable fourth wall of the bracket is used to convert the slot into the tube, thus eliminating the need for traditional elastics or steel ligatures, thereby reducing friction. The evolution of the self-ligating brackets dates back to the mid-30s, so it's not a new concept with the Boyd and the Russell lock system. However, it did not become popular in those days because of its many drawbacks. Mainly, those brackets were very bulky. It was then reintroduced in the early 70s, and from then on, the self-ligating brackets continue to evolve to this day, with many companies entering the market and each one claiming to be superior to the other. Some of the advantages of the self-ligation system or the conventional system, apart from low friction, could be better oral hygiene. It is evident that all of us know that the elastomeric modules have an affinity to attract bacteria, and getting rid of them would surely improve oral hygiene. Other claimed advantages are shorter treatment time and reduced chairside time. Opening and closing the clips of a self-ligating bracket are considered faster than placing elastomeric modules. However, such advantages are very subjective. In a comparative evaluation of chairside time savings, it was found that the self-ligating bracket is faster with a wide range from as low as 7 minutes to 25 seconds. And that's a huge difference. So the advantages of chairside times are very subjective depending upon the patient's skill. The other advantages of the self-ligating brackets would be reduced treatment time between appointments, patient comfort, and better pain tolerance. But such claims or advantages mentioned needs to be validated with systematic reviews and not by such individual authors' experience. And so comes the debate. In the very first systematic review I'm presenting, there is a small debate. A study done by Debbie et al., which comprised 20 randomized clinic trials, they evaluated tooth movement, space closure, expansion, treatment duration, and degree of comfort. And they concluded that self-ligating brackets do not offer any special advantage over conventional brackets with respect to therapeutic efficacy and efficiency. Keeping this in mind, let's move on to the classification of the self-ligating brackets. Based on the mode in which they interact with the wires, self-ligation brackets can be classified into three types: the active, passive, and the interactive. The active brackets have a spring clip that presses against the arch wire, resulting in an active force on the wire. This provides efficient tooth control and better torque expression. The disadvantage of the active would be higher friction and resistance to sliding, and also the aging of the spring clips, which have biomechanical consequences of clinical significance. The advantage of the passive system is the low friction leading to arch expansion, and that's going to be the topic which I would be talking about mostly in today's presentation. Low friction leading to arch expansion. And these brackets have a greater play between the arch wire and bracket, resulting in free sliding. The disadvantage could be reduced torque expression, and mind you, inserting a full-size 1925 arch wire into a self-ligating bracket is relatively difficult and more painful than a conventional system. The interactive brackets are a combination of both active and passive. In the early stages of treatment, they are in the passive mode, and as the treatment progresses to the middle and the final stages, it progressively changes to the active brackets. In contemporary orthodontics, it is the passive self-ligating which has gained popularity and most widely used today. In this discussion, I would be focusing my talk to these passive self-ligating brackets. It was Dr. Damon Dwight who conceptualized the philosophy of the self-ligation, and I would like to quote him. And he said, "Most extractions are done to make space to eliminate crowding. But what about the face, the root of the tooth, and the soft tissues? With the Damon system, we use light forces to convert crowding into posterior arch width, yielding ideal tooth position and better facial aesthetics." I was particularly intrigued by the line, "use of light force to convert crowding into posterior arch width." I think what Dr. Damon was claiming is that by using light form, broad arch form copper nitride wires combined with a low friction passive self-ligating bracket, we are in a far better position to achieve a physiologic mode of action for correcting crowding. Probably a natural or a novel way to gain space. And the two key modalities for his judgment is light force and low friction. So what's all about this light force and arch expansion? Let's go back to Prophet. Dr. Prophet said that light forces produce frontal resorption and heavy forces produces undermining resorption. This graph clearly shows that the difference between frontal resorption and undermining resorption. With the light forces, because of frontal resorption, the tooth starts moving continuously from the second day of force application. The other advantages of frontal resorption are less pain, less harmful to the periodontium, and he says it's very much more efficient. And the philosophy of this passive self-ligation brackets or system is based on this light force frontal resorption. We know that forces applied to a tooth are transmitted to the periodontal ligament, which initiates bone resorption and apposition, leading to tooth movement. In self-ligation, we use light forces just enough to stimulate cellular activity without completely occluding the blood vessels, resulting in frontal resorption and physiological tooth movement, which claims to carry bone along with it, leading to bone expansion. And the second factor what Dr. Damon was talking about is friction. How valid is this low friction with this passive self-ligating system? There are many variables affecting friction, such as brackets, arch wire, ligation, mechanism, and biological factors. Over the last 2 decades, a lot of efforts have been made to improve the reduction in the friction for the passive self-ligating brackets. But are these efforts actually producing its result is what we need to test. In a finite element study done by Gomez et al., they compared the frictional forces during the closure of extraction spaces between passive self-ligating and conventional brackets. And it was concluded that conventional brackets had a higher frictional resistance compared to self-ligation brackets and suggested that the strongest bone and ligament stresses in the conventional system and highest root stresses in the passive brackets. And this was a big thumbs up for the passive self-ligating system with regard to reduced friction. However, here comes another debate. In a systematic review by Hassani et al. Published in the Angle of Orthodontics, where the authors compared frictional resistance between self-ligating and conventional brackets, they concluded that self-ligating brackets produce lower friction when compared with only in the round wire stage. But when it came to the heavy rectangular wires, there was no significant evidence that the self-ligation bracket produced lower friction. So what they are trying to say is when you are on your lower wires, round wires, you probably benefit by lower friction, but as you go higher to your rectangular wires, the reduced friction does not come to play. So there is no conclusive evidence for reduced friction with self-ligation brackets. Some of the clinical advantages of low force, less friction is faster treatment, better treatment qualities and outcome, less need for extraction, easier class 2 correction through the lip bumper effect, better stability and less root resorption. As we will get to know how effective are these claims in the course of this presentation. We are all aware of the different modes of gaining space, starting with IPR, expansion, extraction, distalization of molar, and the list goes on. But with the self-ligation system, the mode of gaining space is specifically focused on arch expansion. Another important factor is to determine how effective is the self-ligation brackets compared to the other modes of expansion. As orthodontists, we consider the rapid palatal expander as a reliable mode of arch expansion, especially in children. However, it comes along with its inherent limitations such as horizontal and vertical bone loss. In a CBCT study done by Kulbersh et al., it was found a reduction in the bone thickness mainly in the molar and premolar region, and when we all know when there is excessive reduction in the bone thickness, it can lead to adverse effects such as dehiscence, fenestration, and in extreme cases, even tooth loss. RME has an adverse effect on the periodontium also. In a study done by Garib et al., they showed that the RME induced bone dehiscence of around 7.1 millimeters in the premolar region and 3.8 millimeters in the molar region, adding to the risk factors with this rapid palatal expander. So the question is, why not use the philosophy of the self-ligation system to produce arch expansion without these potential drawbacks, as it claims to do something as a physiological mode of treatment? Some of the hypotheses about arch expansion with SLB is that the low force needed to move teeth with the self-ligating brackets may enable the lips to more effectively resist the proclination of teeth. That's the lip bumper effect. Greater development of the arch, physiological determined tooth position. We need to put a big question mark to that statement. And with the functional adaptation, there is a Frankel effect in posterior arch widening. And all about the self-ligating system is how to give our patient a broader smile through arch expansion. In this world of marketing and social media, most of our patients would do something to do a thorough search on the internet before they start their treatment. And this is what they get to know when they search for the Damon system. The Damon system gives you a broader smile than conventional brackets. The type of smile preferred by more than 2/3 of adults. And that's a bold statement to make. And this, as duty of as orthodontists, we need to find if this is actually the truth of such claims. This picture conveys everything spectacular about a broad smile. And it's natural that our patients want us to deliver such smiles. But can we blindly believe such claims seen on the internet and marketing strategies? An interesting write-up by Dr. Kevin O'Brien and Jonathan Sandler reiterates the fact that we do not have all evidence for such claims of the passive self-ligating bracket. And they concluded, and I quote, maybe that orthodontists who bought this new bracket in philosophy, based on the promise that they reduce treatment time with less need for extractions, will come to believe that this could be a compelling case of mis-selling. Basically, they are trying to convey that if we do not have scientific evidence against manufacturers' claims, it is the salesman who becomes the king. However, one must remember that this article was written way back in the year 2010, and the newer generations of brackets have undergone many refinements since then. I still remember when I started off my cases with the self-ligation brackets, those clips were very hard to open. Patients had a lot of pain while inserting those arch wires into the brackets. But let me tell you, I'm not going to totally thrash the self-ligating system or tell you more about advantages about the self-ligation system. The advances in the self-ligation brackets and wires have really gone a long way from when that article was written. Keeping this in mind, I would like to share an interesting chat between the colleagues in one of our orthodontic WhatsApp group, which happened a few weeks back. It was a debate on the self-ligation system and its role in the extraction, non-extraction protocol. And I have noted comments from 5 different orthodontics in this group, and I would start like this with the first orthodontist, who says, all my borderline Damon cases treated with non-extraction protocol in children ended up with mild to moderate protrusion and lip incompetency post 18 years of age, or relapse when the fixed retainer gets broken. And to this, the other orthodontist replied, if you have finished with good intercuspation, the chances of long-term stability is excellent. The third comment was a little bit on the humorous point, but it had a point to take. The advantage of treating a borderline case mandating extraction by non-extraction is if you're lucky, you might get to treat the patient twice, or your neighboring orthodontist gets to make some money. And it continues. Another orthodontist had to say, long-term stability of orthodontic treated dentition depends on the status of the periodontal health, loss of integrity of the tooth surface structure, and other pernicious habits. The blame for any tooth movement, even after a decade of treatment, is transferred to the orthodontist. And I think that's a very true statement, and we are, as orthodontists, are victims to such happenings. And probably the most philosophical of all statements, and what I truly believe is written, and it goes like this: I feel everything about orthodontics, after reading yesterday's discussion, I feel everything about orthodontics is subjective. And frankly, this is also my view. And I will show you one case in this presentation where the patient's subjectivity decided my treatment plan. If you look and ask me, or literature tells you, is there any space, any particular case it is advantageous to treat with the self-ligation system, I would say there's nothing specific. But it is advantage to use self-ligation system based on the arch expansion philosophy, which was taught by Dr. Damon White, in constricted maxillary and mandibular arches, which have scope for expansion. Ideally, a skeletal class 1 with an average or mild convex profile, or a mild class 2 or class 3 where adequate expansion is required to camouflage the skeletal discrepancy. And now it's time to look into these aspects of how we can apply these benefits into our clinical situation. I was fortunate to start my first self-ligating case more than a decade ago, in the year 2009 exactly. And I recall she was an intern pursuing dentistry. She presented with a mild convex profile with competent lips. So here again comes the non-extraction versus extraction dilemma. Class 1 dental occlusion on the right side and an end-on molar and canine on the left. Maxillary arch looked V-shaped and constricted, allowing scope for transverse expansion. So I decided that the self-ligation would be a good choice on a non-extraction basis. And that's the cephalometric numbers, borderline skeletal case with mild proclination of upper and lower anteriors and average nasolabial angle. The leveling and aligning stage with the passive self-ligating brackets, and we finished with a rather decent occlusion. I thought I broadened the arches satisfactorily as per the philosophy of the system and placed the bonded upper and lower fixed retainer. She was pretty happy with the outcome of the treatment. The expansion led to the broader smile, the smile that today's patients prefer. And I also was convinced that the self-ligation philosophy was working well. It was well into a year later, I get a call from this patient. This patient had gone to her hometown after completing her internship, where she developed pain on a lower central incisor and had to visit a general dentist who suggested that the tooth had become non-vital and had to do a root canal treatment with periapical curettage. The general dentist also commented that it was the faulty orthodontics that led to this problem, and that left a very bad taste within me. So I went back and looked at her records, and I realized that I proclined the lower anteriors without adequately opening the bite and without not having any proper torque control, which led to the roots hitting the cortical plates, resulting in the non-vitality. This went against the philosophy that light forces with passive self-ligation system increases posterior arch width, creating space to retract the proclined incisors. Now, this is what can happen when you treat on a non-extraction cases without adequately opening the bite or without having adequate torque control. There is a lack of functional interincisal relation leading to trauma from occlusion and opening up of the anterior faces, that's fremitus, which we commonly see in our practice, and that can lead to periodontal problems prone to relapse, dehiscence, non-vitality, and the list goes on. At that time, I came across a very nice article written by Dr. Bertie Milson et al., where they evaluated the changes in the bone thickness and bone height using CBCT. They used the self-ligating brackets with the broad archform copper nitride wires to correct a minimum of 5 millimeters crowdings on a non-extraction basis. And the conclusion from their study was in complete contraindication to the claimed advantage of the passive self-ligating system. They concluded that non-extraction alignment with self-ligating brackets produces dental arch expansion with significant tipping of teeth. And now comes the main concern of worry. Significant bone loss in terms of bone thickness and height was observed on the maxillary central incisor and the mesiobuccal root of the first molar. And that, I believe, is what caused the failure in the first case I showed you. With that read, it was the beginning of the end of my short journey with the self-ligation system. But it was always good to have some hope in any situation, and the hope came with the introduction of the variable torque prescription. One of the inherent disadvantages of the passive self-ligation is the reduced torque expression when compared to the conventional system. For optimum torque expression, friction is a prerequisite which lends passive self-ligation brackets with an inherent disadvantage. This limitation was addressed by the introduction of the variable torque prescription. So we have three options: high, standard, and lower torque brackets, and the advantage is we can mix and match these brackets based on clinical situations. So I began my second case keeping this in mind of the versatility of the variable torque prescription. A 25-year-old patient, mild convex profile with a nasolabial angle, and if you look at the soft tissue profile, it should lean towards the non-extraction protocol. However, the soft tissue and the hard tissue showed a complete mismatch with severe proclination of the upper and lower anteriors and a mild anterior open bite. Even the profile looks satisfactory. On smiling, there's evident protrusion of the anterior teeth, and that was the chief concern of the patient. Severely proclined upper and lower anteriors and a mild anterior open bite. If you see these pictures, it's a clear-cut extraction case. However, the upper arch was severely constricted with a scope for expansion, and this gave me an option to use the passive self-ligation system. So we took our chances with the non-extraction protocol with the idea to expand the arch to gain space, correct the proclination, and take advantage of the newly introduced variable torque prescription. The obvious choice is to prevent further proclination of the upper and lower anteriors was to use low torque brackets coded green color, and we used only on the lower canines we used the standard torque brackets coded blue. As I mentioned, the advantage with the variable torque prescription is you can mix the torque prescription according to the needs of an individual tooth. That's a comparison of torque values between the Damon brackets and the MBT prescription. Mentioning just one example of the upper central incisors, a normal MBT prescription has a positive torque of 17 degrees on the central incisors, whereas the Damon low torque has only 2 degrees of positive torque, and that's a big difference which we can make use to one's advantage. We started with the broad archform copper nitride wires, 013, leveling and aligning stage. Generally, in a passive self-ligation, we place the brackets more gingival for better torque control of the anteriors, and as we get closer to the center of resistance, notice we have applied very light force coil springs between the crowded teeth. And these are very minimally active just to give it the impetus of push for lateral expansion. They are not in an active mode at all, because when we do active mode, the teeth are all going to procline, but we just gave them very light forces to give that impetus to what the self-ligation philosophy was saying of lateral expansion. As I mentioned, these coil springs should be of very light force with minimal activation. We use very light elastics to prevent the proclination of the teeth during the leveling and aligning stage to prevent any further proclination of teeth. And I again mention, these are very, very light elastics, the lightest you can get available, because this is on the round 013 copper nitride. This is where the maximum proclination can take place, and this is the time where we can prevent further proclination and land up with an excess proclination before we start doing any other thing. The broad arch form 1425 copper nitride wire is probably, according to me, the main stay arch wire where maximum arch development occurs, and this should be kept for a minimum of 8 weeks. You see the arches are still developing, and at this stage, if you compare the intercanine, molar and premolar width, there is a 1 millimeter of arch expansion. I was not too satisfied with this sort of expansion. I thought the Damon system will give me at least 3 to 5 millimeters of expansion. However, that did not occur. Unlike the previous case scenario where I just left the patient, I wanted to be a little careful with this case, so I took a mid-CEF, and we realized that even after using the variable torque prescription, we were not adequately able to upright those incisors. I realized that just depending on the self-ligating philosophy to get adequate arch expansion and gain space was not actually doing its job. I was then contemplating other modes of space gaining, and I'm an ardent fan of the IPR, so I decided to go with the IPR. IPR looks like a very simple procedure, but let me tell you, there are certain guidelines one has to follow to get the maximum benefit out of IPR. Today, IPR is consistently done with the aligner therapy. It's becoming very famous with the aligner therapy, but it was popularized way back by Dr. John Sheridan in the early 90s. A good read is an article in the JCO titled Guidelines for Contemporary Aorta Stripping. Here, Dr. Sheridan recommends of placing separators before the aorta stripping. These separators open up the interdental spaces and gives the operator visual access for more controlled IPR. Dr. Sheridan stated that a total of 9.7 millimeters per arch can be achieved, and that's a sizable amount to play around with. So we started IPR from the posteriors to the anteriors on a round stainless steel wire. A passive molar stop averting the mesial end of the buccal tube served as some sort of anchorage. Retraction was done using power chain, one tooth at a time, like beads in the chain. All this was done to conserve the small little space you have achieved with your IPR. Buttons were placed on the lingual side, both on the buccal and the lingual side, and retractive forces given from both the buccal and lingual sides to have a more controlled type of retraction. Now, the question comes, when is the right time, or is there any specific time to do an IPR? For this, I'm showing you these pictures of another ongoing case. In the previous case, I had started IPR after leveling and alignment. But in this case, pre-treatment, there is severe crowding, and if we are planning on a non-extraction protocol, I'm sure that we cannot depend on the doubtful arch expansion philosophy of the self-ligation system, and surely I would need to do IPR. So in this case, we are initiating IPR as early as possible to prevent round tripping. We don't want those anteriors during alignment go too much forward, and that's going to cause round tripping, and then we go reverse once again. So I started IPR right from the beginning stage. If you know the concept of driftodontics, that's what we are not using any retractive force. We're just giving those blocked out canines some space to move around. That's all. No retractive force at this time, and we have attached a mild active coil spring between the lower incisors and canines just to give it some impetus for a little bit of distalization. A very good note is written by Dr. Sridhar Kannan in the book called The Treatment Protocols for Practitioners, brought about by our own Indian Orthodontic Society in the year 2016. And according to Dr. Sridhar Kannan, he says it is very important to check for enamel thickness with IOPAs before we start IPR, leaf gauge to accurately measure the space, hand strips are still the safest and least invasive. IPR more than 0.5 millimeters, do it incrementally. For those of you who are doing a lot of aligner mechanics, take this point. If you really want to do IPR of more than 5 millimeters, it's better that you do it in stages, or you're going to get the drawbacks of sensitivity, foot impaction. Polishing of rough surface followed by fluoride application is a must. Another good read of clinical significance is written by our very editor of the JIOS, Dr. Vignesh Kailasam. And in that article, it's a systematic review, and according to him, this article was published in the AJODO, and what they found out, it's a very interesting observation. They found out that thickness of the enamel on the distal side was greater than on the mesial side by an average of 0.1 millimeters. And mind you, you might think 0.1 millimeters is a very small amount, but when you're contemplating 0.3 and 0.5 millimeters totally, 0.1 millimeters of clinical significance. And this is very important for the clinicians planning intraproximal reduction, a common procedure that is routinely done for clear aligner therapy. I'm going to stick to my passive self-ligation, so don't bother about that. So where are we getting? We got a reasonably amount of retraction with the IPR. I must say that. Of course, the arch alignment is also, the expansion is also going on along with this time of the philosophy. The next most important step before debonding is the torque expression and settling of the occlusion. It definitely takes a little longer time for arch torque expression of the passive self-ligation system. The reason why is there is a greater play between the arch wire and the bracket base, so you need to be patient if you want to get proper torque prescription in a passive self-ligation bracket. I like the quote by the legend Dr. Vic Alexander, and as far as torque is concerned, he mentions you need to give enough time for the arch wire to cook well in the bracket to get a good torque expression. So be patient with the passive self-ligation with regard to torque expression. Again, in a conventional ligation, when we feel we have lost torque or want to incorporate more torques, we use those torquing bends with our rose torquing pliers. But let me tell you, to make a bend on a 1925 wire, a torquing bend, and insert it into a slot of a passive self-ligation bracket, it is very, very difficult. And that's why the versatility of the variable torque prescription comes place. All the third molars were extracted to prevent relapse potential. This is a very, very important point, because when you keep expanding, you are encroaching on the posterior spaces. So it's ideally, before you deband the case, you extract all the third molars. For reasons beyond my control, I was not able to settle the posterior occlusion on the right side, as the patient was leaving to Korea to pursue his PhD studies. There was quite a bit of apprehension in my mind, because I had already failed in my first case, and I was keeping my hands crossed and hopeful that I don't get a call from Korea with a picture of a root canal treated tooth. And to my pleasant surprise, thankfully, 5 years later, he came back after his doctoral studies, and this was the occlusion I got to see. That was nature's way of settling occlusion. You might say I was lucky, but that happens sometimes. Now, coming to the retainers, I told you, once you expand the arches, every tendency to relapse, so I kept the choice would be an excess retainer, but if you're keeping your bonded retainers, try to extend it as posteriorly as possible. I have extended the bonded retainers up to the second premolars, just to see that the expansion effect, even if it was tipping, it really doesn't relapse. And that's the broad smile which the patient wanted, and which I also wanted. The patient was very happy. That's the post-retention step. I have to tell you that post-retention step came all the way from the city of Belgaum just 10 days ago. I wanted to be sure that this case has shown no signs of relapse. So I called this patient and told him I need some x-rays urgently, so as I wish to present this case in this scientific forum. He then told me he's right now working in Belgaum and had no plans to visit Chennai. It's then when I remembered about my good friend Dr. Kiluskar, who heads the department of the KLE Dental College, and I told Kiluskar that I need this help. Kiluskar was very helpful. He immediately saw that a CEF was taken and emailed it to me. So I'm obliged to Dr. Kiluskar for this X-ray. What Kiluskar did to me was not a multicentric study, but for me, it is definitely a multicentric help. It's definitely a multicentric help for me. Thank you, Dr. Kiluskar, for that help. That's the development of arches, remaining stable after 5 years post-treatment. The digital superimposition of the pre and post shows reasonable amount of exclusion in the upper arch. Notice the substantial amount of retraction which we have got with the expansion and the IPR combined. In the lower arch, again, we had expansion about 2.5 millimeters, and because of that, we are able to retrocline the lower anteriors. The main expansion was seen in the premolar region, if you have seen that numbers. And this is a prospective randomized clinical trial study which shows that the maximum development or the development occurs in the premolar region. That's the CBCT. We are pretty happy that the roots were in the center of the cortical plate. And that's the stages of cephalogram from pre to 5 years post-treatment. Now, at every stage, there's been a significant reduction in the open bite, in the proclination and open bite. But what I want you to clearly observe is see the improvement in the airway. If you notice that even after the early stages of leveling and alignment, there is a significant improvement in the airway. It proves just by transverse expansion, one could see an improvement in the airway. We are basically witnessing an increase in the oral volume when we do transverse expansion. We have a notion that only when we bring the mandible forward, you improve the airway. But that's not the fact. And this is a very important criteria because in today's generation, with so much of incidence of OSA, transverse expansion would be definitely beneficial. And that's the airway measurements, an average of 3 millimeters in both the upper and lower pharyngeal spaces from the pre-treatment values. And we did some clinical trials in the department and a very good randomized control study by Dr. Somitra et al., who compared the airway changes with the conventional and the passive self-ligating system, and they concluded there was a significant changes in the airway after arch expansion with self-ligation brackets. And this picture says it all. Appreciate the difference in the smile. Let me tell you, whatever you talk about self-ligation brackets, I definitely would not have achieved this broad smile if I have done extractions. My rationale now is to try and plan for a non-extraction protocol as much as possible. I'm not saying that we have to go overbound, because whenever you have a dilemma between extraction and non-extraction, my personal opinion is try non-extraction. Because you are not only improving aesthetics with a broader smile, there is also other functional aspects like the airways which we are also gain. You see, this patient had a broadened arch which reduced his buccal corridors, and I think he was pretty happy. So I was gaining some confidence with the self-ligation brackets, and the next case was a 90-year-old patient with a straight profile, nasolabial angle was normal, and competent lips. A fairly balanced face. I don't think so anyone sitting out here would have any doubts what type. It's a clear-cut non-extraction case. But intraorally was the problem. Blocked out upper canine. So the hard tissue versus soft tissue and the extraction versus non-extraction protocol continues. Severe crowding in the lower arch also, but gaining, as I said, once we gain confidence, we think everything is going to be under our control. So we took up the challenge to go ahead with this non-extractant treatment using the self-ligation philosophy. Ceph indicates a horizontal growth pattern, upright upper and lower incisors, and most importantly, the soft tissue is very much balanced. Disarticulation is the key for success for self-ligation philosophy. That is, you have to keep both the arches out of occlusion to get adequate expansion. They are commonly, those blue bite blocks are commonly known as turbo bite blocks. You ask me, is there any particular site to place those turbo bite blocks? I would say no. However possible and wherever possible, if you can get both the arches not to occlude with each other, it's well enough. In fact, in a class 3 with a reverse overjet, we place those blue bites on top of the lower incisors. Okay? So, and one more thing. This disarticulation is so very important that it should be started from the day 1 of placing the brackets. And that's after leveling and aligning. Look at those pictures. Look at the roots of the lower anteriors. Seeing those pictures, I knew I was in the danger zone, and one could see that I cannot leave this patient at this stage. We also worsened the soft tissue profile, and we had lost his balance. We have actually ended up with a bimaxillary proclusion, and the patient was definitely not happy with the outcome. And as you know, once we enter the self-ligation philosophy, our thoughts are only confined to non-extraction. So I said, no, let's try something. Implants now, everything now goes to implants, and to prevent extraction, I'm telling you this, I didn't want to do extractions. I wanted to prevent, so the next option we all have is implants. We did distalization with both IZC and implants, the IZC and buccal shelf. One of the drawbacks of the passive self-ligating system was the loss of torque while retracting, and the height of the retraction hook should be given due consideration. An interesting article by Dr. Almeida in the Dental Press Journal, where he clearly defines the biomechanics of extraradicular implants and the height of the retraction hooks. It's a good read. For deep bite cases, he suggests using a long hook, and in open bite cases, he suggests using a short hook. So we did get a significant retraction with the implants, and I felt we are almost there. You know, I thought, okay, the patient is going to accept this sort of alignment. But even at this stage, notice, we are still the profile looks prognatic, and the chief complaint was he didn't like the way he smiled. And he still looked very protrusive. You know, some of the patients come and tell us, I have like a pillow over my upper lip, and this is what he explained to me. So I knew I was getting nowhere with this patient. I had tried out only expansion with the passive self-ligation bracket. Then I tried out implants, but this patient was not willing for his. He's a young medical graduate. And then I thought to myself, I realized that what this patient wanted was what he wanted to look like pre-treatment. He only wanted to correct the irregular teeth. And that's what I call patient subjectivity. We have to, some other patient might have liked the broad profile, but this patient did not like the broad profile. And I had to go with the wishes of this patient. And that was my treatment plan. Ultimately, I came down to extractions. I had no choice. You know, there's no more fight within me to say that this case can be treated non-extraction. So we extracted all the first premolars. We did the regular mechanics of sliding for retraction. That's the pre-debonding. We got a good intercuspation. And that's the pre- and post-treatment comparison. Resulted in a good maxillary and mandibular occlusion. And this is what the patient wanted. He wanted to look something like what he was before. And that's made him happy. If you look at the stages, I took a long way, okay? Now, what the Damon system or the self-ligation system is saying is a broader smile, okay? But we all have to remember that in soft tissue aesthetics, it's not only the broader smile, it's your lip balance. So in this case, we started with a good lip balance, if you see the soft tissue line. Once we did alignment, you saw we are losing out on the lip balance. And post-en masse distalization, we are almost there. And only after the extractions did we get our lip balance. That is a very important factor, which is a very subjective issue, okay? And this is what I want to imply. Patient subjectivity should be our main concern and not our mind process which gets fixed to any particular system. These are the supplementary comparisons. The different stages, excess proclination, the mid-treatment, but somehow got it back on track with the extraction of the upper and lower first premolars and correcting that interincisal angulation. And the cephalometric superimposition shows that after alignments, even with the light force, low friction concept of the Damon system, the upper and lower anteriors proclined, basically telling us that the philosophy of arch expansion has failed in this case, and even after the en masse distalization, we have not significantly improved the facial balance. And it was only after the extractions that I was able to maintain this, get back the facial balance. This patient was a medical graduate, and he was knew what he wanted, a nice personality. I never got upset with him because he kept telling me, no doctor, this is not what I wanted. I didn't come for this. And I had to respect his feelings. It took me a long time, but at the end of it, the patient was happy, I was happy. Now the question could come, why did I succeed with case number 2 and why did I fail miserably with case number 3? The picture clearly tells it all. The obvious reason. All of you know, the first case had a narrow maxillary arch where there was scope for expansion. You see the buccal corridor space, excess buccal corridor space, indicating there is scope for expansion. Whereas in the case 3, which we followed, the arches were already broadened. So there was no scope for expansion. That's how we saw all the teeth coming out. This is a very practical indicator before we take our MRIs and our CBCTs to find out. You know, you see a broad arch form, you know the concept is really not going to work. We managed to get good functional occlusion. That's the canine-guided and the mutually protected occlusion, a very important factor as far as long-term stability is concerned. So this was a deep bite case, horizontal growth pattern. The chances of bite opening is very much possible, especially after extractions. So we incorporated a small bite plane in the upper wraparound retainer. We took CBCTs and we clearly see that after the initial leveling and aligning, the roots were hitting the cortical plate. So I knew, retrospectively, if I had left it in that stage, the roots would have become non-vital. So after the extractions, we are able to get the roots back into the alveolar trough. And in a systematic review by Sendik et al., which compares the effects of orthodontic treatment on alveolar bone thickness, in adults, they found that in most of the studies, there was more chances of reduction of bone thickness on the palatal side. They concluded that these findings are relevant and have to be considered in diagnosis and planning of tooth movement in order to prevent the occurrence of dehiscence and fenestration in the alveolar bone. So, I've been experimenting with the passive self-ligation. Let's see. Now, I would like to show you a skeletal class 2 with a retrognathic profile. Patient having a high lip line, a class 2 div 2 features, 100% deep bite, which made treatment more complex, an endowed molar. Adding to the complexity of the case, the patient had 2 lower incisors missing. That's the cephalometric analysis. Skeletal class 2, with a retrographic mandible, horizontal growth pattern, and a reduced facial height. The cervicular vertebra shows that the patient was in the accelerating stages of growth, so we could make use of the pre-pubertal growth spurt to improve the skeletal, sagittal, and vertical relationship. Basically, we could improve the growth. We strapped up the upper arch with those passive self-ligation copper nitride wires and brackets. What we did in this case was a fixed anterior bite made with an inclination in the acrylic plate. We commonly use the term sweat bite plate for this. This not only provided space for the eruption of the posteriors to correct the deep bite, but also helped in posturing the mandible forward, a functional appliance concept. Now, if we need to put any other functional appliance, we would have to wait till the initial alignment was completed. Actually, if you need to put a forces functional appliance, we need to get into the 1925 stage. And by that time, we'd have lost so much of our growth. So by taking this advantage of sagittal development along with the broad copper nitride wires by giving the transverse expansion, we were gaining both skeletal and vertical and sagittal correction. Even in the advanced sync system, functional appliance, the advanced sync, where they tell us to put the appliance in the first stage of treatment, you can never place an advanced sync in such a deep bite case. You have to wait for the deep bite to open. So this was a very different mode of treatment. Basically, we are achieving both sagittal and transverse expansion simultaneously, the foot and shoe principle by McNamara, advocated by McNamara. So once the bite had sufficiently opened up, we strapped up the lower arch. We continued with the sweat bite plate. This was the stage after leveling and aligning. We had a class 1 molar, but we still had a excess overjet. And the reason for that is we had pre-treatment initially 2 missing lower incisors. We planned to procline lower anteriors to correct the overjet. Since it was a horizontally growing patient, we could afford to keep the lower incisors proclined. And this is an appliance called the Transforce, developed by Dr. William Clark. The widely used TID block appliance originated with him. For this patient, we specifically chose this appliance because it was only attached to the arch which required treatment. As I mentioned, this patient already had a class 1 molar. So any fixed functional appliance like your forces is connected to both the arches, and any arch difference would have its reciprocal effects on the other arch. Okay, so the blue bite were bonded on the lower incisors. That's basically to prevent the anterior arm of this appliance from slipping. Post-transfers, we have sufficiently corrected the overjet by proclining the lower incisors, and this was the post-treatment extraoral photos. A fairly decent occlusion to end up comparing to what we were. We were able to open the bite satisfactorily, and the arches were coordinated. If we compare the pre and post cephalometric, a marked increase in the lower facial height, probably the effect of the sweat bite plane and the combined mandibular advancement. the foot and shoe principle. There is also a marked improvement in the airway with an increase of almost 4 millimeters in the upper pharyngeal space and 3 millimeters in the lower pharyngeal space. The reason for this marked improvement in the airway in this case was because of both the transverse expansion, and we somehow managed to keep the mandible in the forward position. That's the superimposition, and we see that the molars are erupted, and we see the soft tissue balance also getting corrected. The soft tissue confirms the balanced facial height with the increase in the lower facial height and the lips in the lip line, which I was saying of significance in the previous case. We got a good lip line. And that's the broad smile compared to the pre. Probably the success in this case, I believe, was the combining the transverse and the sagittal correction simultaneously, taking advantage of the growth spurt. Now let me tell you, the main reason I presented this case is to stress on just one point, that it is not the design of the bracket, nor the broad arch-form copper nitride wires, but it is the biomechanics of treatment that will always stand the test of time. Till now, we have come across class 1 and class 2 malocclusion, and I'd like to end my case presentation with a class 3 profile. A mildly concave profile class 3. Intraorally doesn't look like a typical class 3. Normally in a true class 3 skeletal, we see proclination of the upper anteriors giving scope for decompensation. But in this case, the upper anteriors were in an upright position, giving no scope for decompensation. And this had a significant decision on my treatment plan. The lower anteriors were retroclined, and that is the standard form of a skeletal class 3 malocclusion. So instead of doing the surgical protocol, I decided the easier way out to treat this case on a non-extraction protocol. The cephalometric numbers showed that it was a severe class 3 with an A and B of almost 7 degrees or minus 7 degrees. And we read in our textbooks anything above -5 is a clear-cut surgical case. But I went against this extraction policy, the surgical policy, and then tried out with the non-extraction protocol with the passive self-ligation system. So we planned on en masse distalization of the lower segments using the buccal shelf implants. Even after bringing the lower anteriors into an upright position, we were still not able to get a positive overjet. And there was no scope for retraction. I was in a dilemma now. I couldn't retract the lower anteriors anymore. So the only option I had was to procline the anteriors. Initially, the upper anteriors were in upright position, so we had some chance to procline the upper anteriors. For those who have been trained in the Beck's appliance, this is called as a loop arch wire. It's probably a very complex arch wire, but it was used in the initial stages of decrowding. During our days in the early 90s, we didn't have copper nitride wires. We used to use this looped arch wires to bring about crowding corrections. Now, the advantage of this looped arch wire in this particular case to bring about proclination was that it was a round wire. Normally, in any protraction utility arches, we have a rectangular wire which will not allow you to do a free tipping. In this case, we wanted free tipping. So we used the looped arch wire in an active form on a passive self-ligating bracket which already has reduced friction, and this helped us in the easy tipping of teeth to correct the overjet. And this is the finished occlusion, molars and canines, a normal class 1 relationship and a positive overjet. That's the pre-treatment and post-CEF. We camouflage a skeletal effect without surgery. We're making use of the passive self-ligation bracket and a looped arch wire which helped us tip the upper incisors. That's the comparison, and that's the pre and post. Patient was happy with the outcome of the treatment. I like to base my surgical versus non-surgical protocol decision on the patient's extraoral features and not on the cephalometric. Even though an A and B was 7 degrees or -7, I was not convinced that this was a surgical case. I'm not saying that you cannot do this case surgically, but my rationale is, why do you want to go and subject the patient to a surgery when this result can be achieved with using this low force and less friction policy? I'm actually eagerly waiting to listen to Dr. Eric Lu's lecture tomorrow on the non-surgical management of skeletal class 3 malocclusions. I'm sure all of us would take back a lot of important points from this lecture. You may have noticed that none among the 5 cases I displayed had an extraction protocol planned from the beginning. There's one case I started non-extraction, but I had to extract. But there was not one case I started on a extraction protocol. So are you going to ask me, you have every right to ask me actually, is the Damon system or the self-ligation system not useful for the, for the extraction protocol? And I would say no. But what I would actually say that the advantage of the self-ligation system of arch expansion is really not needed in an extraction protocol. Okay? But one can take use of the other benefits like reduced chairside time, better oral hygiene. So there is nothing to say that the Damon case or the self-ligating case is a non-extraction protocol. I would like to share some insights on the newer generations of self-ligating brackets, one of which is the Damon Ultima. These brackets looked after the inherent drawbacks with enhancement in the design aspects and re-engineered for smoother tie wings for patient comfort. Now, just a mention about the insignia brackets. Digitization plays an important role as far as precision treatment planning. The three main advantages of insignia are customizations of brackets based on individual treatment needs, clear precision placement guides or jigs, and customized arch wire. Having seen the overview from my lecture on the philosophy and my clinical cases, it's time for a critical appraisal of this self-ligation system. If you want to have a thorough, thought-provoking and balanced overview of the self-ligation system introduced by Dr. Damon, a good read would be a guest editorial by Dr. Sheldon Peck in the Angle Orthodontics 2008, titled, "So What's New About Arch Expansion Again?" where he literally tore down the Damon philosophy. He mentioned that this system was appliance-driven, non-extraction therapy leading to impacted molars. There is no proper evidence there is buccal bone expansion. Arch expansion to correct a fully erupted, labially blocked out upper canine would have debatable post-orthodontic stability. And that was what I saw in my case, which I showed you. And he comes out with a very significant quote: "Patient care, not market share, should be everyone's foremost goal." On a personal level, I thought Sheldon Peck's article was a thought-provoking because he had an unbiased opinion. He criticized the philosophy of saying that the self-ligating brackets had nothing good to say, but he quoted something good about the copper nitai wires. He says, there is still something good about the Damon approach. The marvelous super elastic copper nitai wires that are the centerpiece of this technique have remarkable properties as initial decrowders. Although they would not be appropriate for every treatment plan, these wires should be a part of every orthodontist armamentariums. On a personal experience, this article has changed my attitude to never compromise on substituting the copper nitai wires with the traditional nitai wires. Sometimes many of us try to cut corners because of the many reasons involved like cost, but I realized though the inventory might be higher for getting the different sizes of copper nitai and its cost, never substitute with regular nitai wires, because the concept of arch expansion is that you have to use those very light forces. I mentioned Dr. Profit's what he mentioned. You cannot afford to occlude the blood vessels to get those transverse expansion. So if you don't compromise in the initial stages, I am sure you will definitely end up with an uncompromised finish. An interesting article by Ghetto et al. On the load deflection characteristics of thermal nitai versus our traditional nitai showed that in low friction mechanics, thermal nitai, that is our copper nitai, are preferred to super elastic nitai in the aligning phase during lower working forces. And the conclusion of this article reiterates the fact that one should never compromise the significant role of the copper nitai wires. Now, having some insight about the importance of the broad arch form copper nitai wires, it's time to investigate if this arch wire or the bracket, which has a significant role in the transverse expansion. Is it the wire? Most of us get confused. Is it the wire which is doing this mantra or the bracket which is doing this mantra? And so we decided to do a study. Before that, we read an article by Attic et al. Who used broad arch wires on self-ligating brackets and conventional brackets to evaluate the maxillary arch expansion. And he concluded that the broad arch wires did not play a significant role in arch expansion when compared to conventional and between the conventional and the self-ligation system. However, this was a two-dimensional study, and we really cannot go with the results of a two-dimensional study. So we undertook a project in our institution, and we studied the effects of the broad arch form wires on arch development with the passive ligating brackets and the conventional brackets using the broad arch form wires. We had a total of 60 participants divided into 3 groups of 20 participants each. In group 1, we had the MBT brackets with the standard arch form, that is the normal arch form size. In group T was the MBT with the broad arch form wires, and the group 3 was the passive self-ligating bracket with the broad arch form wires. This was the sequence of wires we used. We used the traditional sequence given by the self-ligation brackets, and in the group 1 we used again the normal brackets, but these were constricted arch wires. We evaluated the changes in the bone thickness and height at the start of the treatment. These measurements were made at 3 millimeters and 6 millimeters from the cemento-enamel junction. We used 3 sites for measurements: the upper central incisor, the first premolar, and the mesiobuccal root of the first premolar. We also checked for the changes in the arch width and the arch perimeter at 4 different sites: the intercanine, interpremolar, second premolar, and the intermolar width. These measurements were tabulated, we did the statistical analysis, and now comes the results, which everybody was awaiting from the research project we did. Results of the CBCT measurement showed all the 3 groups, whether you are using passive self-ligation with combined copper nitride wires, there was a significant amount of tipping. But in group 3, the passive self-ligating brackets with the broad arch form copper nitride wires showed maximum arch development with the least amount of tipping. I just mentioned all the 3 groups have tipping. What we are trying to prove is don't believe this self-ligation system that you are only going to get bodily expansion. There is a significant amount of tipping. However, an increase in the bone thickness in this particular group, passive self-ligation with the broad arch arm wire, was seen only in the premolar region, but there was an actual reduction in the bone thickness and height in the incisor and molar region. In the group 2, which is the conventional brackets with the broad arch form copper nitride wires, it shows very minimal arch development and was associated with a reduction in the bone thickness and height, and the unraveling of crowding occurred due to the tipping of teeth. And the group 1, that is the conventional with the standard wires, showed no arch development with significant reduction in bone thickness and height and excess of tipping movements. The scans also showed an expansion on all the 4 sides, and the premolar region was where we saw the maximum amount of expansion. So the non-extraction alignment of teeth was most expensive with the broad arch form wires combined with the passive self-ligating. This produced lateral expansion with an increase in the arch width and the arch perimeter. However, it was also associated with bone loss in the incisor and molar region. Broad arch form wires, when used with conventional ligation brackets, are associated with undesirable tipping of teeth with significant bone loss. So some of the questions that needed answers are, is the expansion skeletal or dental? Is there actual pain reduction? Is there actual proclination reduction? Is the overall time duration less with self-ligation? Whether, how it works, how is it the copper nitride? Is the variable torque prescription actually working? Does the extraction, self-ligation prevent extraction? I hope I have answered some of these questions. But I still know that most of you will not be convinced that everything in the self-ligation system is absolutely beneficial. So the debate versus extraction versus non-extraction continues right from 1911 with the Angle versus Dr. Case. And where are we today? The truth is somewhere in between. Any philosophy that needs to stand the test is of high quality evidence. As of now, there is evidence to show there is mild expansion with the self-ligation system, along with significant amount of buccal flaring or tipping. Whether this is enough to treat all cases non-extraction is a definite no. The Hollywood spine. In carefully selected cases and at the hands of an astute clinician, the self-ligation system can work to one's advantage. After all, the prescription is a paintbrush. The orthodontist is the artist. We decide if the outcome is the same. I have one slide more before I like to thank the people. This is a quote from one of my friends. He asked me that he uses only self-ligation brackets. And what he said is, it's like using a car. You get used to the automatic transmission, you'll never give it. But my suggestion to you is to take a test drive. So with that, these are the take-home messages, and I want all of you to go through these advantages and disadvantages. And I think the concept is probably good, but never take it in the full-blown method. The most important thing is case selection. That's the end of my presentation, and before I end my presentation, I would like to thank the institution where I work, Savita Dental College and Hospital, headed by Dr. Deepak Nalaswamy, a visionary par excellence. He is setting up dentistry to all new levels in our country. Dr. Rajagopal is our advisor. He was my teacher. And Dr. Arvind, the fellow orthodontist, a young and dynamic leader, and we are going great guns. I'm very happy. The staff are very cohesive, and I want to thank all my postgraduates, and particularly few names, my former postgraduate students, Dr. Rama, Dr. Shruti, and Prasanna. There's so many people I would like to thank, but I always believe that my postgraduate students are my greatest treasures in my life. And the greatest joy for every teacher is to see his or her postgraduates go one step ahead of them. And I sincerely thank all my postgraduate students for all the help they have given me. My mentors, Dr. Krishnaswamy sir and Dr. Lord Mahindra, I was under their wings, and they carried me through this profession, and I will be very, very grateful to them. My family, the sacrificial love of my parents, I will never forget. My wife and 2 children are the essence of my life. The picture shows a very serene look at everybody's face, but let me tell you that they are not the same. Sometimes the anger flares up, and that's when I flare up with my guitar, and I love to compensate with my guitar loudness. My son, I'm happy that my son is pursuing orthodontics, but I hope that, and he's in the audience today, but I hope that one day he has his own ideas and doesn't just believe what his father says. And if I have to ever get emotional during this presentation, it's when I see those pictures. My post-graduation, I'm a little emotional. Both of them, they both literally held my hand during those wire-bending cases, during those case discussions, and even till today. And we have been with each other, not only during the good times, but even when the storms of life have thrown at us. And I thank the Almighty for these two of them. And to all the postgraduates, even if you're not taken much from my lecture today, you can take back how your postgraduates, the love and friendship you can share with your postgraduates. We are not always serious. That's the pictures where we are in the higher spirits. The one in the center seems to be the most sober, but when it comes to the gray matter, he probably stands the most. And I would like to take time to thank and wish the entire organizing team of the 58th IOC. I think they have put their best efforts, and their combined efforts would be like the winning India T20 team. And I believe this organizing conferences committee would also be the winning squad by the end of the 3rd day of this conference. Finally, and most importantly, my sincere thanks to the entire executive committee of the Indian Orthodontic Society. They are the torchbearers of our society. And I want to thank our president, Dr. Jayesh, our secretary, Dr. Sanjay, and Dr. Silju Matthew. The president, the Smiling Bharat initiative, conceived by Dr. Jayesh, is going to be a platform where it's a survey of more than 1 lakh people, and they are going to submit and help the government for guidelines with our malocclusions in our country. And I would quote Reverend Martin Luther King, and he says, "I see many young faces, and I dream that these young orthodontists in our country, with their zeal and never-ending curiosity to learn, would carry the torch of the IOS high and hold our nation to be second to none." I would like to leave this podium. Before I like to leave, I would like to share a short 1-minute video showing the tribute of the Indian Orthodontic Society towards our nation. And may I request those of you who wish to stand, please stand, as this video represents the sovereignty of our country, our national flag.
अपना है दिन ये आज का, दुनिया से जाके बोल दो, ऐसे जागो रे साथियों, दुनिया की आंखें खोल दो, लहरा दो, सरकशी का परचम लहरा दो, गर्दिश में फिर अपनी सरजमी का परचम लहरा दो, लहरा दो,
Thank you and God bless you all. Thank you, God bless you.
Thank you. Bharat Mata ki Jai. Thank you very much, Dr. Ashwin, for this wonderful presentation. I may now request you to please come ahead to receive token of appreciation on behalf of the organizing team.
I would now like to call upon stage Dr. Silju Matthew to present a certificate of appreciation to our chairperson for the session.